Good morning. Thank you for joining us this morning and welcome to the Humphrey School. My name is Scott Kiefer. I'm Vice President of Public Affairs at Blue Cross Blue Shield of Minnesota. I'm delighted to be here again with my friend Professor Larry Jacobs. I want to thank Professor Jacobs for what we've accomplished with our health reform series over the last 4 years. I'm particularly excited to welcome former Governor Pawlenty. Thank you for joining us, Governor. As well as Senator Bergland, former Representative Tom Huntley, many others who were pillars of Minnesota's healthcare policy development over the last several decades. So thank you for being here. It's a real pleasure to have all of you, in fact, joining us here today and lead us in recapturing the spirit that led to Minnesota's health policy innovation. I also want to thank, I don't think Paul is here yet, but I want to recognize Democratic DFL leader Thiessen, who encouraged Professor Jacobs to have this forum where we can hopefully capture the spirit of innovation in the past and use that to propel us forward. So thank you to Representative Thiessen. I hope others will acknowledge his leadership in this area. We're delighted as well to be joined by Noam Levy, who's an intrepid traveler chronicling healthcare policy innovations around the country. And I think it'll be interesting to hear what Noam can bring forth, whether it's something in Baton Rouge, where you've spent some time, St. Paul, and other locales far and near. So thanks for being here again. Noam was here once previously. I suspect that much like the political dialogue broadly, the views in this room around the Affordable Care Act are as varied as what we hear on the television and in the political discussions. But the fact of the matter is that ship has sailed, and we need to move forward as a community and a state. So I'm really excited about today's schedule. The reality of the Affordable Care Act and moving forward, in as much as we've had success along the lines of expansion of access and expansion of coverage, numerous questions remain about healthcare cost, about higher deductibles, cost sharing, and I can tell you, I at Blue Cross and my colleagues continue to hear about that. No surprise to many in this room. I think the key at this point in moving forward is that we really need a new commitment to improve healthcare quality, delivery, and patient engagement. Patient engagement is so important. Each of us carry our smartphones, yet we probably spend a lot more time shopping for that smartphone than we ever do a physician looking for a procedure if we're having a hip or knee replacement or something else. So I think that remains the key, and I think probably the fundamental difference between where we were in 2008 and the panelists here that served on that task force versus where we are today in terms of the technology and enabling that. And I would say that from my view, as a member of the recently convened Task Force on Healthcare Financing, the good news is there's a lot more agreement with respect to delivery reform, information technology, patient engagement than there is disagreement. If we look at the report that was released by the task force just about 3 months ago, those delivery reforms, most of them are practical, common sense, and we'd hope that they find their way into legislation without haste, although I'm not going to hold my breath as we move into the election year. But I think the ultimate work is for the brain trust that's here, the history in this room, and the ability to propel us forward and to break through the logjam that we currently have, and how we might also learn from many of the innovations that Noam will share, and to propel us and move forward in a new way. So today I look forward to the reflections of Governor Pawlenty, other members of the 2008 task force, and our discussion to connect those innovations with what's happening on a national basis throughout the United States. And Professor Jacobs, in his eloquent way, will blend it all together and we'll walk out of here with a new commitment to move forward. Thanks very much. Governor, would you like to come up?
Well, good morning. It's a delight to be with you. Thank you for braving our rush hour in the Twin Cities to be here at 8:30 to be part of this forum and this discussion today. I'm very appreciative of Larry Jacobs and the Humphrey Institute for their continued commitment of convening thoughtful people who care about good public policy in this room and at this institution. And Larry Jacobs is always an honest broker of these discussions and somebody who has got a sincere interest in trying to advance good public policy, good discussion, and advancing the cause of improvement in Minnesota. So thank you for your leadership. Larry, we really appreciate it. Representative Thiessen and others who inspired this gathering, thank you very much. We appreciate that. I see other familiar faces in the audience. Dr. Maureen Reed is here. Other task force members. We have Representative Carlson, who I serve with in the legislature and has been such a longstanding, well-meaning, and really effective legislator on behalf of our state, members of the healthcare community in Minnesota. I think Representative Huntley is here, if I remember, saw him out here. Tom, good to see you as well. Senator Berglund, luminaries from Minnesota's healthcare, recent history, and continued important voices in this discussion and debate across Minnesota. So it's a delight to be here and share some reflections about 2008 and subsequent. You know, a lot of times in politics, when something is very complicated and multifaceted in a world where everything gets reduced down to almost cartoonish proportions these days, this is a discussion that doesn't lend itself very easily to modern day political discourse. It's better for policy discourse, so that's why I like these kinds of discussions even better. But if you had to distill all of this down to a few basic questions and answers, it really comes down to, in healthcare, you know, what are we going to provide? How are we going to pay for it? And who decides those resource allocations? And there's a ton of philosophical underpinnings behind each of those questions. There's a ton of mechanical and systems underpinnings behind each of those questions. There's a ton of equity and fairness and efficiency questions underneath all of those questions. But, you know, a wise person once said that you can distill most public policy discussions down to a triangular tension between liberty, equality, and efficiency. And you see that play out in healthcare discussions now and in previous decades as well. Professor Jacobs today asked me to focus really on the 2008 Transformation Task Force. You might wonder, well, why are we sitting here talking about a task force that happened 8 years ago? I think because, you know, first of all, that task force was assembled in the spirit through legislation that Senator Berglund and Representative Huntley and many others advanced and I signed, in the spirit of the Minnesota tradition of bringing together people outside of public office who are stakeholders, interested participants, informed and concerned citizens to contribute to the discussion. So the task force was, I think, a very stellar group of people who came together with a certain amount of goals in mind, which I'll talk about in just a moment, and put forth under the guise of 5 basic principles a set of policy directions and recommendations, some of which we adopted and passed into law in 2008 and subsequent, some of which still remain unfulfilled or underfulfilled as a premise or as a goal. But not to say that the task force was the be-all and the end-all or its report was the be-all and the end-all, but it was, I think, directionally important to the discussion, not just in that moment of time, but even further as we go forward today. I used to joke when I was in office to talk about healthcare, and again, this is just a joke, so it's a little off, so don't take it literally or too seriously. I got to put these disclaimers in these days because I get angry tweets and emails, and you know, Pawlenty spouted off about this or that. You know, I said all you really need to know about most healthcare, at least financing decisions, is to go to a wedding on a given weekend. Go to 2 weddings on a given weekend, and I'm from South St. Paul, so our weddings used to be in, you know, places like the basement of St. Augustine's Church, and go to one wedding where there's an open bar, and then go to one wedding where there's a cash bar. And you'll see 2 very different sets of behaviors. And you don't need to be Senator Berglund and spend your life in the intricacies of healthcare policy and financing to understand what I'm talking about. You know, when something is perceived to be free or is perceived to be unlimited and you don't have to pay for it, people treat it and consume it differently than if they have to pay for it and be conscious of the consequences of that. Now, that's way oversimplified for purposes of a discussion around our healthcare delivery system, but there is a core common sense basic truth within that that is reflective of the system. I'm old enough to remember the day where we had indemnity fee-for-service healthcare delivery systems, setting aside the government programs for a moment. And the system was basically, again, oversimplified. A person dressed in a white coat or other white garb would come in and say, I think you need X, Y, and Z. And the patient with very little knowledge or insight or ability to assess whether they needed X, Y, or Z would just defer to the person in the white garb. And what wasn't known or said very well in those days and in those times was the person in the white clothes got paid for how many procedures they performed in what was called a fee-for-service delivery system. And so if I'm the provider of the service and I get to self-regulate regarding how much service I'm going to provide, and I get paid more based on the volume of the service I provide, take a wild guess about what's going to happen in a system like that. It's not irrational for the people in the white garb to say, I think you need a lot of different procedures, and it's in your best interest. And by the way, I'm going to get paid more by doing more in volume. Well, now time and circumstance and data and transparency has revealed some things. And what it's revealed is, volume isn't necessarily a measure of quality, notwithstanding how volume oftentimes makes patients feel better, including myself. When I go to the doctor here at the university, I'm loyal to my alma mater, if I get a lot of stuff, I feel like I've been treated better. But unless you take the time to understand, did I need all of those things? Was that transparently visible to me? Are those things effective? Could I have received them somewhere else in a different form, at a different price, or in a more efficient manner? The consumer is not in a position to make the kinds of choices and decisions that you'd make in a normal, healthy marketplace, or at least modified marketplace environment. So all of that, morphed into, in the 1990s, a managed care model, which again, Minnesota was, as it always is, one of the first in the nation to pioneer new things. And the managed care premise was, the plans were going to take in a per capita payment, and for that per capita payment, they were going to manage the healthcare delivery of their patient load within their subscriber base. And then they turned to the providers and tried to negotiate discounts against a fee-for-service model, at least a traditional fee-for-service model. And then those discounts also were coupled with attempts to manage utilization. And when you have then HMOs attempting to manage utilization, if they do that in a way that upsets people, which guess what, it often does, those people then go to their elected officials and say, my service or coverage wasn't what I expected it to be. These services were denied. This wasn't covered. This was out of scope. I think you should pass legislation to put it in scope. And you begin to see the politicization, in part, of utilization decisions and managed care decisions in ways that may have been appropriate, but obviously there was beginning to be a convergence between political decision-making and utilization and managed care. But in any event, that model had its limitations for, I think, obvious reasons to everybody in this room. And then the next iteration of all of this morphs into a different kind of model, which I think was envisioned by the 2008 task force. So this 2008 task force, chaired by Representative Huntley and then Commissioner Cal Ludeman and a luminary panel of Minnesota experts on the topic, under the legislation was given a number of charges, but one principal charge was do something about the cost. And the healthcare costs in Minnesota overall had increased 52% in 5 years. 52% in 5 years. So the costs were unsustainable, but the legislation also said we need you to reduce healthcare expenditures by 20% by 2011. We need you to limit the growth in healthcare expenditures to CPI plus 2%. We hope that you'll aspire to cover all people by 2011. We hope that you'll improve the quality, or your recommendations will lead to improving the quality and safety and reduce racial and ethnic disparities in the healthcare delivery system. We hope that the recommendations will reduce the rate of chronic illness. We hope that you'll put forward strategies to change payments that will increase quality and reduce costs, or reform the payment system, and other miscellaneous changes. There were 13 people on the commission. There were mostly governor appointees and 4 legislators. And like I said, it was co-chaired by Representative Huntley and Commissioner Ludeman. So they went about the business of their work and issued a report I won't go through it all, but there were 5 principles for those of you who aren't intimately familiar with the report, that the report said there are 5 principled things that we think are directionally important to the healthcare reform discussion. Number 1 is we need to improve the health of the population. And they put particular emphasis in the 2008 report on, well, at least what I would call lower hanging fruit, relating to weight management, obesity management and reduction, reducing binge alcohol consumption, reducing tobacco use, and a few others. And the report speaks to some educational strategies, some best practices strategies, and some public policy changes that were focused on those lower hanging fruit imperatives. Regardless of how we got there on a number of those fronts, or at least made substantial improvement on a number of those fronts, including, by the way, significant reductions in tobacco use. And so I signed into law, unrelated to this discussion, the extension of the smoking prohibition or ban in Minnesota to bars and restaurants completely, which I think most people now appreciate. It was controversial at the time, but if you ask people today, do you think that was a good idea? Most people say, of course. Now, by the way, the day I signed that bill, I was running from the governor's residence down Summit Avenue, and one person who I think probably was a smoker rolled down their window and flipped me off and yelled out that, I was some sort of, communist or something. I can't remember the word, but it wasn't pleasant. And I nodded. And then within 30 seconds of that happening, I don't think the person who next came by saw me running and stopped me and said, thanks for signing that. That's one of the greatest things you've ever done. And I'm not even, I don't even like you. So I had an interesting dichotomy. But in any event, there was some good progress made on those fronts. And the report did a number of other things. It said publish goals in this regard. Let's start to define and measure. And this is a theme that permeates the entire report. Let's start to define what we're really after. Let's put some aspirational goals out there, and let's also put some relevant, user-friendly, transparent measurements around it as well. Senator Bergland was, I think, helpful, and others were too, in pushing the idea of annual health assessments in this regard. You see now the prevalence of annual health assessments, either online or in person, in many of the plans and programs, both in Minnesota and across the country. The report called for an increase in the so-called tobacco tax or tobacco fee, and there were requests for increase in differential in premiums as it relates to things like tobacco use and weight. The second principle that was propagated or put forward in the report was to improve quality, cost, and patient-centeredness. And this really spoke to the idea of moving further and more aggressively towards evidence-based medicine, that it is as much science as it is art, and we need to make sure that we've got evidentiary standards and measurements around the practices of medicine and the results that come with it. And the emphasis was on measuring and reporting quality, and also they advanced with respect to e-health records and e-health systems to have a more systematic, reliable, and uniform approach to how we measure these things. There was also a sense that we need to start paying for different kinds of care and stop paying for care that is suboptimal or doesn't work. And then related, principle 3 was you got to restructure the payment system. And restructuring the payment system meant trying to get more provider accountability for the total cost of care. This is something that has continued to be a prevalent theme in subsequent reforms. That requires empowering consumers with relevant information to give them informed choices and responsibility. It also talked about the need to have measurement and practice changes around chronic care. As you know, a big chunk of the healthcare costs continue to be in the treatment not of primary care, although that's important as well, or certain episodic conditions, but the chronic treatment of chronic care is a huge factor in the overall cost of the healthcare marketplace. And then one thing that Senator Bergland and I and Huntley, Representative Huntley talked about and people grabbed onto is this concept of baskets of care. We're going to try to transform how you pay for things from a fee-for-service model or a per capita basis to a basket of care that would encompass, at least for a particular identifiable procedure. You might not be able to do it for everything, but all of the ancillary costs, services, and charges in one basket, and begin to view these as a series of baskets of care and costs around that as opposed to individual procedures. And so you don't get separately charged for the anesthesia, separately charged for the prep, separately charged for the medicine that gets applied, separately charged for this, separately charged for that. If you're going to get, for example, a knee replacement, a hip replacement, a stent put in, there is a basket of care around that is more uniform in its pricing and more contained or all-inclusive in its nature as a way to make it simpler, easier, and more defined, and to pay for it in a way that's more market-oriented. So this was going to involve major shifts in the marketplace. It was going to change the model significantly, and I think directionally was very, very appropriate. The fourth principle was to reduce the overall cost of the healthcare system. This task force recommendations were very aspirational in what they wanted to do, and they were going to try to, relative to baseline, again, this is a relative measurement, not an absolute measurement, relative to baseline, reduce the cost of health care over a certain period of time between then and 2015 by about 20%, net of what it would cost to do some things that were going to be added as part of the program. And then lastly, increase access and affordability. And the task force said, we've got to have a healthcare system that has guaranteed issue. We're going to recommend the merger of the individual and small group market as long as that doesn't have cataclysmic or overly disruptive effects. We're going to still allow and encourage some variation in premium for things like behavioral health decisions like smoking and weight and age. But beyond that, we're going to try to get to a more uniform premium system to take out some of the volatility in the system for individuals and groups and marketplace modeling. They wanted to have Section 125 plans for any employers who have 10 employees or more. They wanted to move to a private nonprofit exchange as an option for people to use for procuring their health insurance, and then define an essential benefit set and mandate coverage. Now, I didn't agree with all of the report, but nonetheless, the report was robust and rigorous. Let me just step back from the report, though, and talk about my view of what we tried to do during my administration and where we sit now. We have a number of very significant things that have happened since 2008 that are probably more transformative than anything that happened in 2008. But in my administration, we required e-prescribing. We thought that would be efficient. We required or suggested or encouraged healthcare homes as a way to get more people to be more conscious of their primary care provider, and to get primary care providers to take a more holistic view of the patient experience from a patient-centered perspective. We provided cost incentives for people to improve quality and to improve outcomes. We created the Minnesota Health Information Exchange, which was an attempt to kind of connect electronically medical records for people who are going to be presenting themselves in ways that are unpredictable in a system that wasn't always repetitive as to where and when and how they presented themselves. We required uniform billing codes and procedures. We started Q-Care, which was an attempt to integrate quality measurements and aligning payments to improvements in quality. We stood up a RX Compare website, which put prescription drug prices on the website for people to compare. We created the most comprehensive nursing home scorecard in the country. We created a new system that related to providing bonuses for chronic disease management, particularly as it related to diabetes and heart disease. We're the first state in the country to require reporting of hospital errors, medical errors at hospitals. We created the Smart Buy Purchasing Alliance, which related to some of the themes regarding purchasing that I just mentioned before. We required the disclosure of price information for the 100 most frequent or prevalent procedures on an average price basis. That was through a system called Minnesota Health Scores. We took the CGIP, the State Employee Group Insurance Program, and added a fourth tier to it and put some more aggressive co-pays and deductibles and co-shares in that in a way that drove down the costs and the premium impacts in the CGIP plan in a way that was, I think, very beneficial. We advanced before it became somewhat less necessary under current law, but we advanced the idea of importing prescription drugs from Canada. I was accused of, being reckless in that regard, and I said, show me the dead Canadians. I don't see a lot of dead Canadians, from all of these tainted and horrible drugs, and more. But we are in a system now where, let's be candid, it was a system that was not coordinated, not integrated. It was born in an era of fee-for-service where great deference was given to providers without much transparency or understanding as how the system worked. It morphed into a managed care model, particularly in places like Minnesota, The managed care model sort of wrung the low-hanging fruit out of the system, but there's only so far you can go in managing costs through utilization management. So that sort of ran its course, at least in its, as originally intended. And now we have moved into an era where we have advanced at a national level. President Obama's initiative has substantially advanced access, but I think it remains to be seen whether we have really dealt with the quality and cost issues. I would say we have not. So is it true? And by the way, in Minnesota, the access issue was important, but even back in 2008, the rate of uninsured in our state was 7 or 8%. It bounced around depending whether we were in a recession or not. But we were first, second, or third, I think, in the rate of uninsured in the country, the lowest rate of uninsured in the country. So we had a challenge in Minnesota, but in relative terms, not as big as much of the rest of the nation. So I think you can say the access issue has been substantially addressed, whether you agree or disagree with the president's approach. It has been substantially addressed. But I would say we haven't fundamentally solved or addressed the quality issue, and we haven't fundamentally addressed the cost issue. So what to do about that? I'll just close and then take Larry's questions. In my view, you got to get back to what we know is common sense. People can't consume things endlessly without some more skin in the game, and they can't help manage that from a patient standpoint unless they have very user-friendly information about what stuff costs and what their alternatives are and what their incentives and consequences are for not making wiser choices. I like to view it as a road with guardrails. This is an extraordinarily complicated area. You can't expect individual people who are busy and have a lot of life distractions and sometimes life limitations to spend huge amounts of their time trying to navigate the internal plumbing and workings of the healthcare delivery system. But at a basic level, we're going to have to get people to have more skin in the game regarding the decisions they make, and those decisions can only be meaningful if there are user-friendly points of information available about what their options are and what their, again, incentives and consequences are for choosing wisely. I think you know all of that, but it hasn't really happened. There have been pilot projects, there have been directional efforts in this regard, but we haven't fundamentally made the pivot. And part of the reason is it's really hard to do. If somebody's going to say, as somebody said to me when I was governor, who are you to tell me what the best practices are in diabetes care management? I'm up here in fill-in-the-blank city, and this is part art, part science. I've got my own view of what diabetes practice is, and so it starts with, can you even get the providers to agree to what a quality of care standard is? And of course, in Minnesota, we have something called the Mayo Clinic and the affiliated organization called ICSI, where we can say, okay, don't listen to me, the governor. How about if we benchmark against the Mayo Clinic? You got a problem with that? You're telling me you know more about diabetes than the Mayo Clinic? Maybe, but please, come and help me understand that. So, agreeing to the benchmarks, agreeing to what's quality, agreeing to what's achievable outcomes, and then trying to do that in a system that is so Byzantine in its lack of integration, lack of coordination, lack of synergistic technology, lack of interoperability in terms of communication and understanding is very, very difficult to do. So it is a slow, tough slog, but every discussion like this, every reform that might take place is additive, and I think we just need to keep pushing, and it may take another couple decades on the quality and cost side of it, but I think directionally that's where we have to go. And so, with Larry, those are some opening thoughts. I look forward to the questions, and again, thank you for being here and being part of this discussion.
We've missed you.
Not everybody has missed you.
No, it's kind of very skillful synthesis of 3 decades of conversations. I want to ask you about what you think was the big innovation, because it's interesting to me, at least, that the idea for this session today starts with Minority Leader Thiessen saying, we've been fighting ferociously now over health insurance reform, and we've lost what had been this pretty broad effort across party lines, business involved, civic community involved, about the cost and quality issue in terms of delivery of healthcare. How did that happen? How was it that Minnesota, and before the Affordable Care Act episode, was able to bring together such a wide and diverse group of people to focus on delivery reform?
I think, first of all, Minnesota just has a tradition of civic participation and concern regarding a whole variety of public issues, and this being, top of the list or near the top of the list for many people. So it's consistent with the Minnesota culture, Minnesota tradition about how public policy gets made. And number two, the pressure points, both in terms of access and costs, were becoming unbearable. And so we had really smart people and well-intentioned people trying to figure out, let's not let the perfect get in the way of the good. Let's find a place where we can all live with, both in terms of policy and politics, and at least make some progress. And I think that was the spirit that Senator Bergel and Representative Huntley and the commission, the task force, as well as ultimately the legislature, and we entered into it. But nothing focuses the mind like a crisis. And when you have 50% increase in healthcare costs in 5 years, and the model's just, it's mathematically unsustainable. Everybody knows it. If you look at the federal budget, you look at the state budget, you look at the pie chart of where the money's been, where the money's going, healthcare and social services are growing 2x, 3x, 4x, 5x the rate of inflation. The economy's growing at 2% a year. We can't afford to pay for it in its current form, so we have to reform and improve it. And we were in one version of that crisis 8 years ago, and I think probably another one's coming.
One of the themes that you talked about that comes up again and again is the commitment in Minnesota to collecting user-friendly data. And to some extent, that sounds like a pretty geeky issue, collect data. I mean, I'm an academic. For us, it's only data that matters, and you want to collect it. And yet that strikes me as one of those areas where there's broad agreement, there's been sustained agreement, and yet there's been surprising difficulty in getting to data that's not gobbledygook, that is actually provides meaningful comparative data. I think I remember way back we were talking about this, and you were referring to kind of online data about car purchases, and just that kind of very simple data that a consumer could use. Why has it been so hard, despite the many decade agreement now, about getting data that consumers could actually use as if they were discerning shoppers?
It's been hard because systems are not integrated, systems are not uniform. It's been hard because it takes a lot of time and practitioners are busy and they haven't historically viewed this as a priority. It's been hard because people can't agree on what to measure and how to measure it. I'll be candid with you. In 2008, and I think subsequent, there wasn't great data and isn't great data on outcomes. And so we substituted quality treatment protocols as a proxy for outcomes. So that was the bridge, and I think still is the bridge. People fight about what are we measuring, why are we measuring it, what really is quality, and so that's still coming, still unfolding. But in the meantime, we reverse engineered and said, okay, we'll just benchmark against best practice protocols as a proxy for outcomes with the belief that they will lead to better outcomes. And by the way, you don't have to boil the ocean. If you just start with diabetes, you start with heart disease, you start with certain cancer treatments, obesity, and end-of-life care, you've got 80% of the dollars. And again, each one of those is a mountain of its own, but you don't need to do 10,000 things. If you could just get your arms around 3 or 4 of those, or even 3 or 4 of the biggest pieces within those 3 or 4 pots, you've got most of the money.
You're quite agile in thinking about policy, obviously very skilled as a politician. And what's really struck me, and I would say this particularly with my class, the academic class, and policy geeks over the data issue, is that we tend to think of this as a technical issue. It's just a matter of collecting the right data. And over time, I've come to the realization, and I'm curious what you think, that this is really about business models. And it's about the interests of the different stakeholders in the group. And the data is not neutral. It has consequences. That if you are a provider that's kind of below the line in terms of cost and quality, you're going to suffer.
Yeah.
And so we've seen this kind of defensive action to protect the business model. And sometimes that's meant, obstructing data collection and the creation of consumer-friendly data. Does that sound reasonable to you or not?
I think it does sound reasonable. And let's face it, from a consumer standpoint, somebody's going to have to deliver this to them in a way that gets their attention. So, the CGIP experience, I think, is instructive. We didn't say, here's 10,000 pages of data on 10,000 clinics across Minnesota, although you can go find it if you want. We just said, look, you can go anywhere you want, but if you choose in a tiered basis to go someplace that's really expensive, that we deem to be not very high in quality, in this case, the provider of the service, the state, you're going to pay a lot more. And if you go somewhere that we deem to be higher in quality and lower in cost, you're going to pay a lot less. We said, preserve your freedom. You go anywhere you want. You got liberty, endless liberty. You choose, Mr. and Ms. Consumer. But if you choose upstream on high cost and low quality, you're going to pay a lot more. And guess what happened? The market migrated rationally to lower cost, higher quality alternatives, and the overall cost pressures in the program dropped substantially. It was very simple, almost rudimentary in its design, but it worked. And if you want to steer people away from not very good providers with not very good results, crank up the costs on going to those providers. And somebody has to decide. So again, back to my opening point, what are we providing? How are we going to pay for it? And then importantly, who decides? If you accept the premise that we can't pay for all the appetite that exists, somebody has to be, as George W. Bush unfortunately said, the decider. And the choices in that regard are the government can decide, some third-party manager can decide, or the consumer can decide, or there's a hybrid model that blends one or more of those elements together. We clearly have had more of the first two than the third, but we got to tip the calibration more towards getting consumer engagement involvement and I would say even a simple way. As to how do you get the benchmark or the quality outcomes, I think over time technology is probably going to leapfrog this whole discussion. I think the idea that this cabal of clinics and providers and hospital systems and plans and the government are going to figure all this out in a way that's going to materially change where we're at over the next 5 or 10 years is probably, shall we say, optimistically aspirational. And so I think what's going to happen here and a lot of other places is you've got artificial intelligence, big data, algorithms, data analytics that are going to set in, mostly out of Silicon Valley, not out of the government or out of some highly regulated healthcare plan that's going to bust open this discussion in ways that the government can't.
A question just on this point from one of our friends here in the audience. You're talking about a change that would have people choosing wisely. Do people really want that responsibility?
No, but they like to keep their money in their pocket if they can. So, the answer is, we all want all of it. So, when I go to the doctor, the more stuff I get, the better I feel treated. But, I don't say if I get the MRI here versus over there, do you save or I save some money? Do you get paid more? Does somebody else get paid less? So in any event, the answer to your question is no, it's complicated, it's unpleasant, so we have to make it simple, but I think more of the same isn't working, and I think moving this to a consumer-centric model, more of a consumer-centric model is the right direction.
I think this is one of the areas where your leadership had an enduring impact, and I think the fact that we're doing this today reflects that. And so I was struck listening to you that you described the task force work and your administration's work as aspirational and directionally important. And that suggests to me that you really see this component of your administration as mostly agenda setting rather than kind of transformative of actually what was going on. Is that fair?
I think with the exception of the Affordable Care Act, most of the reforms in healthcare have been iterative, not transformational. Mm-hmm. The name of the task force by itself was aspirational, the Healthcare Transformation Task Force. I mean, that kind of implies healthcare was going to be fundamentally transformed. It was directionally altered. So we didn't want to call it the Healthcare Direction Altering Task Force. We didn't want to call it the Healthcare, Change in Emphasis Task Force or the Iterative Improvement Task Force. It didn't sound bold enough. So, and it was in law. Senator Bergland, Representative Hundley, put it in law. So yes, was it fundamentally transformational? No. Was it directionally helpful? And did we make some iterative improvements in subsequent legislation, yes.
And so the kind of tilt that you described here today, I think quite efficiently, is this tilt from fee-for-service to managed care, where the focus is on managing the utilization of care, to a new model that really focused on putting the emphasis on providers with regard to cost and quality and changing the financial incentives with more accurate data. How far are we in Minnesota along that kind of arc?
I mean, interesting progress, interesting pilot projects, interesting one-offs, some incremental and nominative systems changes, but have we moved fundamentally to that place? No. And the old system is I get to come to you, Larry, I'm your doctor. Larry, you need these things like I said. You say yes because you like and trust me. The bill goes to her. You don't even know it other than this is not a bill, pay your $20 copay. I'm fighting with the HMO over, the discount that you've negotiated and my, utilization. But it is not economically viable to have the provider of the service endlessly order up service, the consumer endlessly appreciating more service without regard to knowing whether any of it's any good or costly or impactful, and having the bill go somewhere else. It just, it doesn't work.
I know you've got to run to catch a plane, but before we let you go, let me ask you about one other part of this story, which is the role of the business community in Minnesota. They have been historically a very important component. We're going to have Noam Levy up here. He wrote a terrific article a few years ago comparing Minnesota with Baton Rouge. It's a stark comparison. But one of the things he singles out is that in Minnesota, you've got this remarkably collaborative Minnesota tradition that includes the business community. You're part of the private sector now. Do you have a sense that there's still a deep commitment to health reform in terms of delivery transformation that maybe there was back a few decades ago?
I think what's happened, Larry, is that the Affordable Care Act has been the declarative change. And notwithstanding everything I just said over the last 45 minutes, many people, I think, correctly see that as going the other way. In other words, if you have to go to the what are we going to provide, how are we going to pay for it, and who decides, the how and the who is shifting to the government. So it's moving in the other direction in the eyes of many, at least substantially. So in terms of Minnesota, I think one of the challenges we've had historically is our own success has bred a degree of complacency. So, if you look at Minnesota's historic healthcare record, we got the healthiest people, top 5 always, depending on who studied, is in the health of our people. We've got some of the longest living people in the country. We had the lowest rates of uninsured. We had, at least by the measures that were available, some of the highest quality, lowest cost healthcare in the country, and on down the list. So it doesn't mean we didn't have problems. We had a lot of challenges and a lot of problems. However, it's sort of people look around and go, what we're doing is kind of working, so we don't need to change it too much. So there's a complacency that's set in, but I also think in the business community, to answer your question, I think their view is, the Affordable Care Act the shoe has dropped. It's moving in a direction that is government-centric. Our voice and role is now somewhat more limited, and there's a sense of almost resignation or complacency or, policy fatalism around that. And then there's people waiting for what they believe will be the dramatic cost boomerang of the Affordable Care Act that's coming. They think you're going to see in the next 3 to 7 years dramatic increases in premiums, dramatic cost pressures, and they believe that will be a window of opportunity to re-engage on reform. But they view it in the current moment as somewhat futile.
Governor Pawlenty, thank you so much for joining us this morning. This has been very helpful, and we wish you well. Thank you very much.
Thank you. Thank you, everybody. Appreciate it. Thanks, Larry. Thank you.
Okay, so now we've got a few members of the task force who are going to come up and join us. Here's Tom Forsyth over here, Tom Huntley, and Linda Berglund. This is going to be good. I'm really looking forward to this. So I'm so delighted to have three of you here. I know there are a number of other folks here who were on the task force, but we wanted to provide enough room for a conversation. And I'm going to give each of these really critical leaders in health policy debates over so many decades a few minutes to respond. I can't avoid calling you Senator Bergland. I apologize. Former Senator Bergland. I had this image from back when you were serving in office that you had a kind of a harsh view about how things had gone. And I actually went back and read some of the press reports. And you had some really pretty critical things to say about Governor Pawlenty and about why he walked away, and you had a sense that there was agreement and he didn't fulfill it, provide the leadership that you expected. Is that your view today, kind of looking back at the task force, looking at what you've been doing in terms of your more recent work? What's your assessment of the task force and its impact, looking at it from 2016?
Well, of course, you look back at press clippings of the process.
Yes.
And the process wasn't exactly very pretty. It almost was a bill that almost didn't happen. So, but what I appreciate about Governor Pawlenty is that he actually did care about improving our healthcare system, and he actually did engage in helping to make sure we did make some changes, and the changes were sorely needed. And so even though, in some ways we were antagonists, we also shared some goals. And we were able to articulate that, and we were able to find a way to get to passing legislative changes that would accomplish those goals.
And what do you see as the kind of the accomplishment from the task force? How would you describe it?
Well, one of the goals of the task force was to restructure the payment and delivery system of the health care in Minnesota. And one of the ways that we wanted to do that was to move away from fee-for-service to forms of capitation that would take place directly with providers. And that might sound strange because obviously we'd had managed care in Minnesota for quite a long time, and they were basically paid on a capitated basis. But by and large, they paid providers on a fee-for-service basis. So, it really wasn't getting us where we needed to be. One of the big questions for us, since most of the money in the healthcare delivery system is in hospital care, and this was all going to be a voluntary, we were going to structure things to provide incentives, but it was really going to be voluntary whether people participated or changed. Would the hospitals participate? And I'm really happy to see that they have. I really am. I think that is partly due to the legislation and partly due to the fact that, we've gone through some hard times, and it became pretty clear to them they weren't going to get, increases in payments. And the way to increase your bottom line then was to get more efficient.
Thank you very much. I'm going to jump ahead to former Representative Tom Huntley. What do you see as the big kind of legacy, the contribution of the task force to today?
Well, we tried to do a lot of things, and our biggest impact is always on people that are on medical assistance or Minnesota Care. And I think that Minnesota was ready to try some new things, and they have done it. I can give you some examples. The governor talked about transfer of medical data. And my wife had a knee replacement, I don't know, 6, 7 years ago, and came down with C. diff. And she was doing going to do the rehab at our cabin because it's all on one floor rather than our house, which is 4 floors. And so obviously we took her to the emergency room in Brainerd, and they asked, and they determined what was, and they wanted to know what her drugs were. They emailed her surgeon in Duluth, which is 120 miles away. He emailed them back, told them to take her off certain drugs that she was getting for the knee surgery. And so right now we can transfer this data back and forth, which didn't used to be the case. And the Brainerd Hospital is part of the hospital system that's actually headquartered in Duluth, Essentia. And but in early March, I fell off my exercise bike, and I don't know if you got to be a bike nut to know what rollers are, but most exercise bikes you couldn't possibly fall off. But the rollers are designed to challenge your balance. Well, I fell off, really hurt my elbow, and my wife took me to the Crosby Hospital, which is not affiliated with the Duluth one. And they took the x-rays. And then the surgeon there in Crosby knew that my insurance company would not cover his doing it, so he recommended that we go back to Duluth. And again, they emailed the x-ray structure to the surgeon that he recommended in Duluth, and when I got there, he was ready to go and he had everything done. So that transfer of data, even between groups that are not affiliated, is off and running.
Good, great, thank you. Tom Forsyth, thanks so much for being here. I always feel like I can count on you for complete candor. So I want to ask you.
I win the Candor Award routinely.
Almost any topic, Tom's good for that. I'll tell you later about the course we taught together. The task force had as its goal, and I'm quoting, fundamental reforms to the healthcare system in Minnesota. How satisfied are you that some of those reforms were accomplished, whether it was the transformation that both Senator Berglund and Representative Huntley are talking about, or the change in the agenda that Governor Plenty was talking about in terms of this kind of directional orientation? Was there a fundamental change?
Almost. I thought I was going to get the legacy question, so I'll just answer that one too. I think the legacy and what you could say is the positive outcome of the transformation task force is it proves we can do it. It proves we can sit down and have these conversations. It proves that good people can come together and come up with good ideas to advance, a policy objective and try to make Minnesota a better place. And that's kind of the legacy I see. Now, did we do it? I would say no, but we made progress. So like the governor, I think it was, iterative. Transformation was a bit of a stretch. We had fully transformative ideas, but they never came to pass. And it wasn't that the ideas themselves weren't good. It was partially the time. And in fact, some of these changes are so big and require so many changes in so many places all at the same time that it's probably too big of a bite to imagine that you can do all of that at once. And so iterative does make sense. And if you look at the arc of healthcare, I'm proud to have worked on Minnesota Care, on behalf of the business community. I think I came up with the provider tax. So if you hate the provider tax, I think it was my idea. And I still think it's a good one. If you look at the arc of that and add all the way to where we are with MNsure and how many people we have insured, when we first were doing these things, decades ago, I didn't imagine we could get to this level of uninsured. I actually didn't think it was going to be possible. I thought like unemployment, there was some sort of number that would be like full insurance. And maybe it would be 5%. That was the number I imagined. Today, I think that number might be 4%. But there's some number below which I didn't think you could go. We have now pressing on that number, which is a time when I thought that couldn't have happened. So we've made tremendous progress. The full arc, and the governor laid it out pretty well. We invented managed care. We invented the HMO. We invented some of the payment models that others have used. In the business community, we did some amazing, innovative work. When the governor mentions the public employee programs and how they actually reduced not just the cost curve, but actually reduced costs for public employees as a whole, that was a model that we developed in the business community that the state adopted. So, I actually think we've done a lot of great things, and the legacy is it shows we can do it. But along came the ACA and sucked all the air out of the room, and we should probably have a conversation about that and be a completely different panel like MNsure, if Subpoint, what the hell happened. But
We have had that panel.
but I
We
think
have had that panel, and you were
But I think we
pretty
could.
candid,
I
as I
think we can
recall.
take most pride in the ideas we brought forward. But I do think we have to acknowledge we didn't get them all done, in part because they were too big, and we still have a long way to go.
So, Tom Forsyth, I want to come back to a lot of the work you were doing about 2 decades ago. There was, and I know there's some people here who were involved in it, these remarkable private sector-led efforts that you were a leader of, the Buyers Healthcare Action Group. There was an effort that started a health plan sponsored by some of the large employers. There was some of the first risk-adjusted premiums, again, being driven by the private sector. I asked Governor Plenty about, is that energy from the private sector still there? And he said no, that there was a kind of a fatalism now. What's your answer? Do you still see the same kind of energy, willingness to kind of provide leadership in terms of transforming healthcare delivery that there once was in Minnesota?
Sadly, no. And I just have to tell you, we have been a great business community. We've done amazing things. And whenever I do this, I always give credit to the doctors. We could not have done it without them. Doctors, every time we've wanted to work on innovation, have been willing to do it with us, and they've always, exceeded what I thought was possible. The insurance industry here has been great. It helps that they're sort of captive, but honestly, together we've all worked on these things very well, very long, very hard. In the business community, we had for a time sort of a golden moment when there were a lot of people with a lot of experience nearing the ends of their career, and they wanted to make some things happen. And so we did. We created a new payment model. An entirely new payment model. We couldn't get anyone to sell it to us, so we created our own insurance company. It wouldn't work without risk adjustment, so we created the first working risk adjuster in America. Usually at every one of these stages, various people would come in and tell us it can't be done, routinely. After we threw our money on the table, they would say, well, not only can it be done, but we can do it, and you should be working with us. So we put our money on the table. We did great things. We lent all of the expertise we had wherever we could to the government to try to benefit public programs and the state as a whole. And I don't think that moment exists anymore. The ACA changed the game. And one thing to know about the business community is we're very good at reading the rule book. So if you change the rules, we get it. We read the rules, we read the rule book, and now we understand that that's the way the game's going to be played. And I think right now a lot of people in the business community are very much on the back foot, waiting for the backside of the ACA. And as hopefully many of you know, it is not funded. And there's a whole bunch of ugliness coming that will have a serious impact on employers and employee plans and the cost of those plans. So the business community's read the rule book very carefully. We're now working very pointedly on how to defend ourselves and our employees to what we think the future will hold, sadly.
Linda Berglund, you were kind of a pioneering legislative leader on healthcare for some years. You're now at Hennepin County. And again, you're working on some healthcare issues along with other issues. How has your experience in Hennepin County maybe informed the way you think about some of the changes that resulted after the task force in terms of changing the incentives to providers of care, creating more integrated collaboration among providers?
Well, I think what you find at the local level is that controlling healthcare costs is like peeling an onion. There's a layer and another layer, and you get there and then you find another layer. And that's good in some ways because, it keeps giving you more to work on. There are some basic things, however, that I think Hennepin County's working on that are good, that we all need to learn from. And in regard to improving the outcomes of healthcare for poor people, you need to combine social services with it. And housing is one of the important ones, but there are others, proper food, nutrition, transportation. You can't just expect the healthcare delivery system to become efficient if you don't merge the social services.
And do you think the task force kind of encouraged that sort of integrative approach to the range of medical services, but also bringing in social services? Is that kind of in the water?
It was one of the concepts behind the healthcare home that was part of the 2008 legislation. But I think the payment reform actually has encouraged it as much as the healthcare homes have.
You were a ferocious advocate for coverage and for those who were not getting adequate access to medical services. And this was one of the battle points with Governor Pawlenty back in 2008, how many people would be brought into MinCare. Looking back on that, do you think that was a reasonable compromise, or do you wish there could have, or was there a more generous compromise that could have been reached?
Well, I think over time the whole thing worked out very well.
Because of the expansion. Yeah, and that actually is I think one of the questions here, which is by not taking the direction you were pushing, it kind of left a lot of the pressure for expanding access that you would later see behind the idea of enacting the Affordable Care Act here and expanding the Medicaid program.
I think actually the biggest thing that pushed us forward in terms of being one of the early adopters of Medicaid for people without children was the veto of general assistance medical care by Governor Pawlenty.
Yes.
And it just created such a crisis among the provider community. They were losing so much money that there had to be something else done.
And that was both on the Medicaid expansion side, but also I think it probably fed into some of the transformations within Hennepin County.
Oh, definitely.
It forced innovation. We're going to talk about a little bit later with Hennepin Health that might not have been imaginable or tolerable under the normal circumstances.
The block grant that General Assistance Medical Care became taught Hennepin County that having a prepaid form of payment was the way to go.
Tom Huntley, we're almost out of time. A question from our audience. One component of the 2008 reform, of course, was the state health improvement program. Was that program transformative? Was that something that really worked or not?
Well, I think it was, and the you look at all the providers, and they pay attention to, if they're not rated very high, then they will change what needs to be done in order to compete, and so they don't look bad. So I think that part has very much worked. What was not mentioned so far is and it was not part of the, I don't think part of the task force, but Minnesota is sort of led the country again in health plans, or excuse me, not health plans, but health providers sharing. If they can save money, they share money. They share the savings with the health plan, and they get to keep some of it, and that seems to be working in Minnesota. We were way ahead of the rest of the country doing that, and that's just a typical example of Minnesota doing its own thing and getting it right.
There's been a lot of discussion already this morning of how the Affordable Care Act has been a game changer. It certainly changed the policy environment. The ability to talk about healthcare delivery reform has now become quite difficult. It's one of the reasons for this conversation today, because of the toxic politics around the Affordable Care Act. But what is also striking, and Tom Forsyth, I want to ask you about this, how many, and Representative Huntley, how many of the ideas in the task force became integrated into what the lawmakers in Washington were putting together? And I know both of you kind of were working with various people in Washington. Is it the case that the 2008 task force was actually an idea generator for parts of the Affordable Care Act? Tom Forsyth.
Well, I can assure you that it was, actually. So not only did the key members of Congress who were driving the reforms, not only were they familiar with the ideas in the Transformation Task Force, but they were open to putting them into the bill as best they could. So I spent hours and hours with Senator Max Baucus's staff, giving them every single idea I had. Think of this, maybe that. If you did this, then perhaps. And it was that kind of a conversation for days. And, frankly, Senator Franken as well was trying to work on the, from the outside in with his small group, pushing for pilot projects. So it was not the thrust. But after we got by the main points, because, fundamentally the ACA is about insurance reform and how to pay for it. It didn't get to the rest. That's what I don't like about it. Because we never got to payment reform. And frankly, without payment reform, you can't get to affordability. Without payment reform, you don't get to delivery reform. And those things just aren't in the bill. Now, that's not so much a criticism. It's obviously a heavy lift to get what they got, but that's what I was trying to work on. So the ideas that we brought forward were not only bandied around the country, but people were very willing to listen to Minnesota on things we thought might work, even if we hadn't gotten it done ourselves. And I certainly made some shots. And you'll find those in the ACA. Some of the pilot project ideas are fundamentally right out of our playbook.
There's a lot more to be said here, but unfortunately we ran out of time. Please thank this terrific panel, Linda Berglund, Tom Forsyth, Tom Huntley. Wow, this is quite the treat to have such luminary figures. Now I want to invite Noam Levy, who's right here. There you are. Noam Levy may have the most interesting job in journalism. He travels around the country writing stories about communities in America that are reforming healthcare. So this is not at the level of what's going on in Washington. It's really at the level of what's Baton Rouge doing, what's going on in northern Maine, and then making comparisons between the states. Noam Levy.
you very much, Larry. Thanks for having me. Larry didn't mention that I actually started my newspaper career at the Duluth News Tribune, though I'm a Bostonian by birth, and actually cut my teeth as a political reporter covering the state legislature, I remember Representative Huntley, and I remember spending time at Willard Munger's Inn on West Duluth and covering a rally by Mike Yaros. I don't know what he's up to now, but I distinctly remember him telling a rally in the Central Hillside in Duluth that what's wrong with socialism? Why is socialism a bad word? And of course he was 20 years ahead of his time, I guess. I want to make two caveats about my remarks. Number one, I'm a Middle Eastern history major, so I'm uniquely unqualified to really write about healthcare, except with the exception perhaps that I studied dysfunctional systems while looking at the Middle East. And secondly, I'm always reluctant to share any insight about healthcare with a Minnesota audience because, notwithstanding some of the issues that Governor Pawlenty and the panel before me brought up, if there's one thing I learned about Minnesota when I lived in Duluth, it is that everybody really is above average here. So I think as a general proposition, the rest of the country has a lot more to learn from Minnesota than Minnesota does from the rest of the country. But that being said, obviously there are challenges everywhere, including here. And I do have I think a terrifically fun job. I do travel a lot around the country looking at how the Affordable Care Act is being implemented, how communities are thinking about what they do for their citizens. I'm a national healthcare reporter. I'm based in Washington, but I'm out of Washington, thankfully, a lot of the time in emergency rooms and federally qualified health clinics and large medical systems and tiny ones from Baton Rouge to Hawaii to Maine and all places in between. And I will say that it's a particularly exciting time, actually, to be covering healthcare, and for a number of different reasons. Now, I take Mike's point about delivery system reform and the Affordable Care Act, and Governor Pawlenty's as well. The Affordable Care Act did not solve the cost conundrum facing either individual states or the country as a whole, obviously. But I do think it has spurred an enormous amount of activity around the country, and in a lot of places, frankly, that were not like Minnesota, that weren't thinking as much systemically about what their healthcare systems were doing. I'll share with you a story. I was in Arkansas not too long ago, and as you can imagine, Arkansas doesn't quite have the health profile that Minnesota does, among other differences. Arkansas has gotten a lot of attention in the national healthcare discussion because it's one of the few states in the old Confederacy that expanded Medicaid through the Affordable Care Act. But I think in some respects, more remarkably, the state is in the middle of a delivery system reform effort that involves multiple payers in the state. Commercial payers, the blue plan there that is dominant, large employers like Walmart, as well as the state Medicaid program. And I spent some time with a orthopedic surgeon in a small town called Batesville, which is in the foothills of the Ozark Mountains. He's one of 3 orthopedic surgeons that serve a pretty large rural area up there. As you can imagine, his patients are pretty low income. Many of them are missing a lot of teeth. And they have a lot of joint and back problems. Now, because Arkansas has implemented a episode of care program in which all of the payers in the state, all of them except Medicare, are paying single payments for total hip and knee replacement, Dr. Jeff Angel and his partners have completely rethought the way that they replace knees, down to the protocols they use preoperatively, to how they track patients after they leave the emergency room, after they leave the hospital, to the very small things such as making sure that all of their patients have a 24-hour number that they can call if they ever have any problems, because there's a financial incentive for Dr. Angel to keep his patients from going back to the hospital unless they really, really need to. Now, that's just one example. I think it's easy to be cynical about a lot of these delivery system reform efforts. Some of the initial data that's come back on Affordable Care Act, on accountable care organizations, on patient-centered medical homes, have suggested that the return on investment on some of these initiatives is minimal, even if there are some encouraging signs. So, and clearly there have been some misses out there. But to the extent that this may be useful, I'll share with you a couple of observations I have, I think, about some of the communities where I've been and some of the common themes that I see sort of emerging in places where I think some of this activity is producing hopeful signs, if not real results, although I think there are real results in some places. One we talked about already today, and I think Minnesota certainly doesn't need a lesson in this, but data collection is sort of a necessary bare minimum, I think, for any community effort. We see this not only here in Minnesota, but you see this in Maine, another leader in sort of community-wide efforts to think about healthcare. Individual communities like Cincinnati have made great strides in getting primary care physicians and others to sort of post their measures. Now, there obviously are big caveats with a lot of this data. I think it's still, the evidence seems to suggest that patients themselves are not yet familiar with sort of how to use that data to shop, but it does inform decisions. This orthopedic surgeon I just told you about gets a report quarterly from the state and from the Blue Cross Blue Shield plan that tells him exactly what his costs are for his patients, what his complication rates are, et cetera. And let me tell you, there is nothing for a surgeon, and I say this as the son of a surgeon, that focuses the mind like seeing how you're doing compared to your peers. And those surgeons look at that stuff pretty closely. And my experience spending time with physicians around the country is that they look at that data very closely, and that sets off a series of conversations among providers, even if patients themselves aren't using that data yet, to actually shop the way they might shop for a washing machine, something which I think there's some question about whether they would do that anyway. But that aside, I think another really, really striking thing that I've seen traveling around the country is this idea of collaboration. This idea, and we heard something about this again earlier today, it's clearly a hallmark of the achievements that Minnesota has been able to rack up over the years. But I think it's in some ways it's difficult to measure, so it is not necessarily always fully appreciated. But the degree of collaboration that one sees in a community like Maine, for example, within the healthcare system, where you have got medical systems, if not totally financially integrated, who have come to a place where they're able to sit down together in some formal way to talk about their care processes. I mean, one of the weaknesses that has been identified with accountable care organizations is that, unlike HMOs, the patients are not limited in where they can go, which puts, I think, even more of a premium on this idea that different parts of the medical system have to communicate with one another. And I was in Bangor, Maine a few years ago, which is sort of pretty close up to the end of Maine, a lot like Duluth, actually. And there are two competing medical systems up there. I think every week, the clinical teams from these two medical systems who deal with chronically ill patients have a formal sit-down where they actually talk about how are their care management processes working and what is the data showing them about how these patients are behaving. Because some of them spend some of their time going to one of the hospitals and some of their time going to the other hospitals, and that level of communication is critical. I think the other part that's important about collaboration is extending that outside of the healthcare system. And again, I think Minnesota's experience with the business community here is instructive and as a model. I was in Seattle, as Larry mentioned, and looking there at how large employers there have helped shape healthcare there. And I think it's indisputable that the large medical systems in Seattle, like Virginia Mason, for example, have changed the way they deliver medical care because the large employers there, Boeing, Starbucks, Costco, took a very, very strong interest in driving lower costs. Virginia Mason completely redesigned its care processes for things like lower back pain because Starbucks came and said, we can't afford to send our people here anymore. You have to figure out a way to make it so that when our patients come here, it's not breaking our bank, because we need our baristas back behind making coffee, and if they have bad backs and you want to operate on every other one of them, it's not going to work for us. So they completely changed the way that they do that because there was this institutional collaboration. A third really important factor, I think, is the political leadership. And Governor Pawlenty reminded me of this, that if you have public officials, elected officials from both parties committed to the enterprise of community health, it changes the entire conversation within a community about what sort of the expectation can be. And it sets in motion, I think, a series of conversations and efforts that can get into delivery system reform that simply can't happen if the elected leadership is not bought into it. And I think this has been particularly striking. Massachusetts obviously was a collaborative effort between a Republican governor and a Democratic legislature that led to its path-breaking health reforms. Arkansas was the work of a Democratic governor and a Republican legislature. But I'll tell you where it's particularly striking is what in places where it hasn't happened. I was in Atlanta not too long ago where, as you might imagine, the Affordable Care Act is a four-letter word. And the effect that has on the medical providers, I was there with a group of other journalists doing a site visit, visiting with federally qualified health clinics and hospitals and so forth. People were afraid to talk openly about health reform, and not just Medicaid expansion, which obviously is the very narrow political issue that was on the agenda in the legislature there, but not even about delivery system reform, because anything associated with health care reform was so politically toxic that providers couldn't talk to one another, and that sort of perpetuates fragmentation in communities that prevents, I think, the kind of discussions that the task force illustrates. That the task force was trying to get to. I'll make one final point and then sit down, and that has to do with money. If I've learned nothing else covering healthcare the last 8 years, it is that nothing talks like money. People change their behavior based on how they're paid. That surgeon in Arkansas was changing the way he behaved because he was getting paid differently. And he seemed like a really great guy. He was very committed as a clinician. He had a great bedside manner with his patients. I spent a couple days with him. I'm sure he was trying to do the best job that he possibly could. I don't think he was out to put in knees just to rack up additional checks for his bank account. He was a committed clinician. But it was the change in the way that healthcare was being paid for in Arkansas that was changing the way he was behaving. And we see this in other communities like Seattle, where the employers are coming forward and saying, we're gonna stop writing checks to you, or we're gonna write checks to you in a different way that got hospitals and clinics to change what they are doing. And I think that's sort of the big challenge for communities now, is sort of how do you, as a community, make that big change in how you pay for health care, since there are still many payers. Medicaid is one big payer in any community. Large employers are paying. The federal government is paying through Medicare. getting all those payers on the same table, around the same table, I think is obviously a huge challenge. But I mean, if they can do it in Arkansas, I would think that other places, even Minnesota, ought to be able to have that kind of conversation about payment reform. So I'll stop there. I hope that was provocative at least. Thank you.
Great, thank you very much. It's very helpful, and there were already some questions in the earlier panels about what else is going on around the country, and you really bring that kind of understanding. And again, what I really like about your reporting, and if you don't follow Noam Levy's reporting, you should, because there's a physicality to it. You really meet people, you can kind of smell the earth in a way from your reporting. So I want to ask you a question I think has come up in both Governor Pawlenty's presentation and then the last panel, which is the 2008, it was the Healthcare Transformation Task Force. And yet the theme that we've heard all morning is this is really not about, kind of the one magic moment. It's iterations. So you've been at this for a while. You've been traveling around the country looking at what communities are doing. Give me a sense of what iteration looks like to you as you go to a community, you look at a change, whether it's Seattle or it's Maine or it's Massachusetts or somewhere else, and then you follow it over time. Is the path one of sticking at it, sticking to it? Is it the path sometimes just throwing up the hands like, oh my God, this is just way too hard. Let's just move on to something else that's more glamorous. What does iteration look like?
I mean, I think it's certainly true that I think it seems that these community efforts wax and wane, as things do in life. As leaders come and go, I was struck by what you were saying about this moment in time where a certain number of business leaders in Minnesota were nearing the end of their careers and perhaps thinking more about their legacy or what have you, and that created a fortuitous moment. I mean, there are fortuitous moments in Massachusetts that allowed that state to do what it did 10 years ago. And I mean, it's very interesting as an outsider coming back to Minnesota and hearing about this sense of complacency or this sense that the energy has perhaps declined because you do see this, I think, coming and going. Arkansas, as I mentioned, is at a moment where they're sort of trying to there's more energy about reform. One other thing I'll say, I think, which is interesting, particularly listening to sort of where it sounds like Minnesota is at this moment, is that the Affordable Care Act seems to have had a particularly rough impact on states that were already ahead of the game. Hawaii has had a pretty rough time implementing the law. They obviously had a pretty close to universal health coverage there. Massachusetts has had a rough time adjusting, and it sounds like Minnesota, it's been a little rough as well. And I think part of that is to be expected. Minnesota was on its way, I think, in important ways to figuring out some of this stuff. And when the federal government comes in, the federal government doesn't tread lightly. And layered on top of that, of course, was the incredible political toxicity of the law, which had a tendency to make further discussion about healthcare reform difficult. That being said, I don't think the vision that the task force set out is more ambitious than, I don't think anybody anywhere has achieved that level of transformation to total cost of care, marrying a capitated kind of arrangement with very robust quality enforcement mechanisms. Nobody's done that yet. But that is in some sense the vision of what I think the Affordable Care Act is setting out to do, and I do think that is a bit of an unfair criticism.
And do you think there's a way, or let me rephrase it, how is it that well-meaning civic leaders and business leaders and government officials can get back to that broad conversation about healthcare delivery reform in wake of the Affordable Care Act. We've got President Obama is leaving office. You know, he's already made plans. He's moving on. Is there some point where it's just going to the fever's going to break, and we'll be able to have these conversations? Because it's the toxicity you're talking about. It's here in Minnesota, and I think a lot of the people, including some in the room, who are really committed to the delivery reform part, to the payment reform part, that've been at this for decades, are wondering, how do we get back to that? Is it gone? I mean, what's the path? What are your suggestions about?
Certainly the Trump candidacy doesn't suggest the fever's broken. I mean, I think it's tough. I'm going to be a little in politics, especially as a reporter, but I think the Republican Party's war against the Affordable Care Act has made that exercise very, very difficult. And perhaps when President Obama is gone, that unifying kind of rallying cry maybe will lose some of its potency. I'm not sure. But the problem is, the party has dined out for a lot of years on casting that law as, the second coming of Karl Marx. It's sort of hard to step back from warning about Armageddon and get back to sort of the more important and consequential discussions about how you change how you pay for health care. So I don't know the answer, I guess, in short.
Question from the audience. It seems that the fragmentation of our healthcare market on the demand side makes it very difficult to control spending. Is it time to move towards a more unified system in terms of payment that would use supply side to control prices and to control provider behavior in terms of payment reform? So again, shift the conversation from this consumer-oriented to perhaps just kind of going all the way to some form of single-payer type of reform.
I mean, I don't know. I think the consensus among folks even on the many people on the left is that the single-payer idea. It's hard to see. We are an iterative system, getting from here to there, but there does seem to be a school of thought, and Milbank Foundation, which in New York does a lot of work with primary care transformation around the country. One of the things that they are very focused on is the idea of trying to, if not unifying the payers into one government payer, which is very problematic for a number of reasons, at least bring all the payers together so that they're doing the same thing, and that is what places like Arkansas are trying to do, so that everybody's at least agrees on the same metrics and on the same rewards, so that as a provider, whether it's a primary care physician or an orthopedic surgeon or a hospital, that you can align your behavior with a sort of a more uniform system of incentives. That, it seems to me, has promise.
So another question from the audience. Does it make sense that physicians should be paid, at least in part, based on patient satisfaction?
We didn't talk a lot about sort of patient engagement, and maybe I should have, because that is a hallmark of, I think, of a lot of community-wide efforts who put kind of patients at the forefront of that. I don't feel qualified to answer whether physicians ought to be paid based on patient. I mean, there's some suggestion that if you did that, clinicians in the Northeast would be really disadvantaged, because I can say this as a Bostonian, we're more unpleasant people, and we tend to judge our clinicians more harshly, perhaps.
I was born in Brooklyn, so I know just what you're talking about. Another question, you were talking about the importance of collaboration as one of the distinguishing features of states and communities that are moving forward. In one of your stories, the one on Maine, this was a terrific story where you were kind of following this small army of medical folks and social workers who were going into homes of people who were chronic illness with a tendency towards kind of high-cost interventions, hospitalization, and so forth. And part of the point you make there is that we know, and this is from your story, that 99% of healthcare decisions are made by patients in their homes, not in a doctor's office. What does that tell you about the nature of keeping people healthy in terms of integrating different types of services?
Well, one of the things which has gotten a lot more currency in the past couple of years is this discussion of social determinants of health. And you do see this, I think, beginning to seep into the conversation in communities that are committed to talking about the health of their citizens. And one of your panelists, I think you mentioned it earlier, about sort of how do you talk about housing and how do you talk about these other issues. And should communities devote more of their resources to those kinds of issues rather than to just the medical spend? And I think that the consensus is yes, they should. But realistically, is Congress or the Minnesota State Legislature, for that matter, going to take $500 million or $500 billion out of healthcare and move it into housing and education? I mean, probably not. So I think sort of one of the things which I'm interested in looking at around the country is the degree to which medical systems, because of some of these incentives that we've been talking about, to lower readmissions, for example, are sort of looking to extend their mandate, if you will, or at least their responsibility into patients' homes. I'm getting ready, hopefully, to go to Memphis later, because one of the major hospital systems there has been working with African American churches in that community to create actually a formalized kind of partnership where the churches can take greater responsibility for post-discharge patients, because the hospitals recognize that their own capacity to do that is somewhat limited. So I think that is an interesting thing to watch within the healthcare system and within communities that are sort of serious about these kinds of holistic approaches to patients, is the degree to which those other services can be provided.
We're just about out of time, but I want to come back to actually the first issue you mentioned, which was the importance of data collection. And you referenced the importance of data collection with regard to the provider in Arkansas. And the question that's been kind of floating along this morning is about the ability to create usable, accessible information for consumers so they can play this role that's been assigned to them to be the discerning shopper. What have you seen around the country in terms of success in actually getting to that promised land where there is this accessible data at the fingertips of consumers? Is that happening? If so, what does it look like?
It's a good last question, because I don't have much to say. No, I don't think, I haven't seen very much of it, frankly. I mean, and if you listen to folks who actually get in, like the Healthcare Cost Institute, I was just listening to their folks last week in Washington talk a little bit about this. They analyzed sort of healthcare spending and tried to isolate what percentage of the healthcare spend is actually shoppable. Maybe it's an MRI, for example, or a knee replacement. But as a percentage of what the entire community spends on healthcare, that's pretty small, even if you could design a system that patients would feel comfortable with.
So basically, your point on data is invaluable for the providers, invaluable for community collaboration, but this kind of large edifice of a model about consumers as discerning shoppers who have this accessible, usable data and are able to use it, that's more questionable.
I mean, I just haven't seen very much evidence. Maybe it could be done in such a way. I haven't seen it as much.
Great. Thank you very much. Really appreciate. We're going to have a. We're going to have a 15-minute break, and then we've got two terrific panels. We've got really some of the most innovative people in Minnesota working on healthcare delivery reform, and then several legislators, including DFL Minority Leader Paul Paul Thiessen. Thank you. We've got two final panels here, and they really pick up on the conversations we've been having all morning, beginning with the 2008 task force and its emphasis on transforming the delivery of healthcare, focusing on payment reform, collection of usable data, and the collaboration among providers. And we're very fortunate this panel is one of the panels I've been really looking forward to, because we've got some of the real leaders here in the state of Minnesota. And if you've got that inkling of things used to be great, well, things are still pretty good in Minnesota. And this panel, I think, is going to show you why. I want to start with Paul Beresford, who's Chief Operating Officer at Entira Family Clinics. Paul runs a dozen clinics. These are independent physician clinics, which those of you who follow this area know have been a bit of a dying breed, and so you're fighting the good fight and a very important voice about delivery reform. Could you tell us a little bit, Paul, about the model that you're pursuing in terms of healthcare delivery?
Sure. Hopefully we're not that dying a breed. Basically, we've over the years we found that to deliver high quality, low cost healthcare, we can't do it in the same fashion. If you go back into the history, you talk about 2008 and such. We started out with measuring quality, and you had to the state and the community started to measure quality. ICSI, which is one of our wonderful resources in the state, pulled all the payers together, and they all agreed to choose specific measures. We talk about data, and want to know how important it is. When we were measured, our first measurement came in on preventive services. That's our backyard, and we were last. I can tell you, in a competitive environment we live in, we were first the next year. So measurement, you can't change unless you measure something, and that's something I think that has been very important. Over the years, we've tried programs called Diamond, which is involved in developing care management for medical care of the persons with depression. It's hard because getting those folks taken care of can take you 6 weeks or more. Finding psychologists or psychiatrists who can get them in. Family practice has the advantage of being able to see those patients right then and there in your office. If we're trained properly, we could help take care of them. To do that, we needed different resources to handle that. And so we brought on care managers to do in-between care. If you know anything about the fee-for-service model of payment, you don't pay for care managers. They're just not done. There are no codes for them. Healthcare Home brought on care management for care payment for care management. The problem is I don't know anyone who can afford to bill for that service. No one does, because it's too expensive to bill for what little you get, and there are barriers abounding because of it. I'll explain that in a second. So basically we looked at it and said, we have these challenges before us to provide high quality care. We have a bunch of doctors in our group that are baby boomers that are retiring. So can we recruit fast enough to replace them? And we found that that was probably going to be very difficult. So the way to do it, sort of a two-pronged approach, is one, redesign our care delivery to become more efficient and more effective. Take care of people at the top of one's licensure. So have doctors take care of sick people, have PAs take care of acute and chronic stable patients, have RNs take care of protocol care, have care managers go for in-between care to help improve the patient's health and such. The problem is a lot of those services, there are no codes associated with them. So if you're adding those resources into the mix, you can't cover them. Or, as I said, the barriers to that, the healthcare home care management fees, which, what a wonderful start. Unfortunately, it runs into the barrier of we allowed patients to opt in and out of care management. So when you get them on care management, you have a diabetic or someone with depression you're following, and you have your care manager call them in between visits. How are you doing? How are the complications of your medications? Are you taking them regularly? Let's do a PHQ-9 screening assessment and so on. And you help them out and keep them as healthy as you can. A patient now gets a copay for $20, and of course the first response is, I didn't see you. Why should I pay that? I want to opt out. Now you can't give them care management. So it's a self-defeating process, the way some of the barriers are put up with. It's unintended consequences. So we sat down and said, we have to redesign this. Let's get our system in order. Let's redesign the way we deliver care. And let's put this together. But we can't do it right away and go broke because there's no way to pay for it. So we sat down with the payers in the community and said, look, here's what we'd like to do. We think we can save money. We know we can improve the quality of care, but how do we finance this? And so after about 3 or 4 years, I have to give Blues credit. Garrett Black next to me here, his organization sat up and said, maybe we ought to try this out as a pilot. Maybe we ought to partner with you and see what we can do to achieve results. So we've been working over the last couple of years developing a model of care to take to the market. We're piloting it coming up this summer. I also know that Health Partners, Fairview, Alina, all have pilots in care redesign moving forward. So I think innovation is alive and well, and we're certainly giving it a try.
Thank you very much, Paul Beresford. It's terrific to have Jennifer Duke-Billis with us. One of the most significant and underappreciated elements of the Affordable Care Act was money that went into encouraging innovations around the country. And Minnesota won one of these grants. It's known as a SIM grant. I had a couple friends, academic dweebs like me, who were on the selection committee, and they told me privately, and I'm just going to share it with my close friends here, that the Minnesota proposal for a county-based affordable care organization was the most innovative they'd seen around the country. And one of the most successful of those efforts has been here in Hennepin County. It's known as Hennepin Health, and Jennifer has been kind of the all-star in putting this together. Could you describe the basic idea of Hennepin Health and why it's been such a sharp change from the usual approach to caring for chronically ill, high-risk Medicaid patients?
Absolutely. Thank you, Professor Jacobs. Hennepin Health, just for those who maybe don't know what it is, because we often find nationally we talk a lot about it and people go, you're from Minnesota? And people in the audience go, we don't even know what's going on. So that is one of those secrets about how do we innovate differently. Hennepin Health is a collaborative but in a defined network working with individuals who are on Medicaid. So we traditionally have worked with single adults. We now this year are working with families and children as well. And it is looking at health care a little bit differently. It's discussing health care as what are all of the levers that we can pull across the county for wellness for individuals, and how do we remove barriers? How do we give people pathways out of poverty? How do we close disparity gaps? How do we use those dollars, putting them at the table to purchase not widgets, but purchase wellness? And I think that's the game changer we have in Minnesota, is the more we can change the discussion from purchasing procedures or services to really saying, what does the individual sitting in front of me need? I am a firm advocate. We do not need more dollars in the healthcare system in Minnesota. We need to use those dollars smarter. And when I talk healthcare, it's not healthcare services. It really is health. It is, in Hennepin Health, it is public health, working together with community clinics, with hospitals, with social services, and with the health plans to say, let's put all of those dollars, which are often in silos, put them on the table, and let's define how do we purchase health for our population in smarter ways. And what we often find is individuals who have barriers in employment, barriers in education, barriers in housing, barriers in walkable streets. The list goes on of what those barriers are to actually realizing financial wellness, educational employment wellness, and physical health wellness, or mental health and chemical health wellness. When you put those dollars together, what you realize is you have systems that can make different decisions. So by putting those dollars on the table, we're no longer chasing a term of care coordination or case management. We're saying, what's broken across the system? It really is system redesign. And we took, early on, we took our top 200 high utilizers, so individuals who were using a lot of services, and we said if there wasn't a catastrophic accident, if they weren't in a chronic illness group, then the system is broken, that individuals are having to cycle through hospitals, through jails, through emergency departments. And that taught us where there's opportunity. As soon as you take that approach and you say, okay, this individual, it really was a transportation barrier, or we're trying to treat a wound, but we can't successfully heal that wound, which results in inpatient visits because they have unstable housing and they're walking the streets all day. That tells you if you can invest your dollars upstream to provide the right supports for individuals that they need, what you do is you rapidly change where those dollars need to be spent. So early on, we were able to free up significant dollars and really took the clinical care entities and social services and said, start pitching us where there's waste in the system, give us a business case, and let's invest differently. So instead of waiting for somebody to show up in the emergency department, let's invest in getting them access into primary care. Let's invest in dental care. Let's invest in non-traditional housing supports. So Hennepin Health has received some great outcomes of investing early in employment, and Linda Berglund was instrumental in bringing that idea forward. But clinicians aren't often taught how to do business cases or return on investment proposals, and so that has been a learning across our system of how do we do that. But in that employment scenario, it was taking individuals who were chronically in chemical health services or mental health services, inpatient, crisis, detox, and getting them jobs. And immediately what people said was they need to be stable for a year in order for us to get them employed. This isn't the population who is employable. The ability to challenge that, because what we were doing is we were releasing individuals from very high-cost services back to the same life situation that was causing the relapse to begin with. And so we're just churning through those dollars. So it was an opportunity for us to say the dollars are at the table. Let's invest up front in employment, in some non-traditional wellness initiatives to say, can we change the line? And what we saw was dramatic reductions in costs, not to say the impact that we had to lives. We did similar in housing, housing individuals and having a 50 to 70% return on investment. As soon as you do those kind of what I call smart government, it really is investing smarter in the people, our residents, and how do we provide those supports. We freed up dollars that now you can repurpose those dollars to the next population that we're not getting our arms around.
So let me just jump in here and ask you, one of the themes all morning has been the aspirational accomplishments of the task force in 2008, and then the limits of its accomplishments on the ground. And one of the main limits that's been emphasized is in payment reform. And as Noam Levy said, people, payment matters. And this has been the theme throughout the day. So tell us a little bit about the payment reform that allowed you to take money that was devoted to Medicaid individuals and shift it to non-medical services.
And I would say that's one of our best kept secrets is people can do that today. So we're playing with the same money that all health plans in Minnesota have, or fee for service. We get the same per member per month. We're in the same competitive market. How we spend it, we have to provide the basic Medicaid benefit set that everyone is entitled to, that is set in Minnesota, but we can purchase above that. So it's kind of value added. So using those dollars, if we believe we're going to get better health outcomes in order to purchase something outside of those more traditional services, we can do that today. And that's not unique to Hennepin Health. It really is connecting systems in order to say, what are the data metrics we want to measure so that we make sure we're not just throwing dollars out the window, that we're truly getting better outcomes for people, and let's invest those dollars differently in those programs.
Great. We're going to come back, but let me bring in George Garrett Black from Blue Cross Blue Shield. Garrett, you've been hearing the really encouraging reports from Paul Beresford, from Jennifer DeCabelis. What's your sense, sitting in a health plan, being a kind of a data geek, Are we seeing I say that in only the most loving way.
I'm an applied data geek, so.
What's your perspective? Are we seeing the kind of transformation that seems to be suggested by our two colleagues here?
Well, I do think that innovation and transformation, and most importantly, collaboration among leaders on the financing and care delivery side, it's alive and well in Minnesota. So the work continues. In some ways, to be a bit Dickensian about it, it's the best of times and the worst of times. We've made great progress with the growth of value-based payment arrangements. So Blue Cross has 500,000 members in value-based payment arrangements. We have implemented products built around accountable care organizations. We have 25,000 people that have decided they wanted to purchase an accountable care product. We've made great progress on adding bundled payment arrangements for orthopedic procedures and expanding centers of excellence and sharing data with providers, Entira, Mayo, all over the state. The challenge is pace and scale. So while we have made great progress, 98% of all payments that Blue Cross makes to physicians and hospitals is still fee-for-service based. And so while we are paying providers for managing the cost of care and improving clinical outcomes and even care coordination, and that's one of the things we worked on very closely with Entira, it's really this pace and scale issue that we've been struggling with our provider partners. And it comes down to business model, and that there's still a fair degree of misalignment, especially from the provider perspective, that they have to change their wholesale system of how they deliver care. Financing is one piece of it, but you can't have a door at Hennepin Health and a door at Entira Family Clinics, or let's imagine two doors, fee-for-service on the left, managed care on the right. The systems of care management, how you compensate physicians, the data analytics that you need for those systems are fundamentally different. So the business model that we are trying to change, and it's iterative and evolutionary, is that transactional fee-for-service business model. And I just wish we could go faster with having the scale adoption of changing the financing and also the care coordination, care delivery mechanisms. And Paul and I have had some very interesting conversations with his clinicians around, what's the cultural pace of change that physicians and other caregivers can adapt to, given that they've been trained and socialized and often incented in a fee-for-service environment.
So when you think about the drivers of change, what are you most hopeful about? I mean, and I put it to you this way, because this conversation has been going on for decades in Minnesota. I think Governor Pawlenty's right that there is an agenda that's been set, very important, and as Noam Levy said earlier, that agenda has helped to bring together a pretty diverse group of providers and civic and business and government officials, but we're still hitting up against these barriers. What are the kind of one or two pivots or places where you can kind of disrupt the system and move it forward?
Yeah, well, I think there are two. With the Affordable Care Act, there's been a lot of attention on implementation, and I do think that takes a certain amount of organizational capacity, and we've been focused on that, at least on the insurance side, for the past couple of years. So while we've continued with our work on these sort of transformational value-based payments, we've had to do other work to adapt to the Affordable Care Act. I now feel that we can put our full attention back into transformation. And I think we have to, from a policy standpoint, we have to create a very strong set of positive incentives to move to value-based payment arrangements and away from fee-for-service. So that it's kind of the coming together, and I think it's somewhat happening in the multi-payer alignment task force, where we are trying to create kind of that standardization and impetus for how do we align payment systems to reward value. I do think consumers and purchasers play a big role in the transformation, because the reality is there's still great and extreme variation in the cost and quality of health care across the state of Minnesota. So if I look at the variation in the cost to treat breast cancer, it's 400%. For knee replacement, it's 250%. And I'm just talking about the cost, but they're equal disparities in terms of outcomes, patient experience. So I do think consumers have to be able to make more informed choices and have some incentive along with other purchasers in going to those high-value choices.
Yes, Jennifer.
I would agree with that, and I would just add that I think we often create programs and we put people into programs, and that's what's not working in Minnesota. I think we really need to invest in people and what do people need and have a flexible enough system so that ideally our clinicians have the freedom to take care of people and do what's right for individuals and collaborate across systems. And then the business simplification. We're not chasing RVUs at hospitals. We're not chasing fee-for-service. That's a behind-the-scenes office discussion that we need to have the funding, support those clinicians, but really that would be the freedom. I don't see it as clinicians that are resistant to changing. I think it's really that business model needs to be behind the scenes, and we need to be free to take care of people.
But just to make it real, you've worked in Hennepin County, you've worked at the state level. You know, these are agencies that have very powerful interests, and protecting their piece of the pie is not a casual concern. Within the health plan world and within the provider world, there's a big commitment to the business model, and making change is a scary thing. It's a threatening thing, and it could be a career-ending thing. So let's talk reality here. How is it that you navigate to the kind of significant delivery and payment reform that we're all talking about through this maze of very powerful, interests and need to support a business model that continues to bring in revenue? Jennifer?
And I think one of the things is to look at the outcomes for people, and it is to make sure we have those metrics and that data-driven decision so that we're not managing widgets, we're not managing RVUs, we're not managing procedures. We really have some clear outcomes. And I think we have a ways to go in Minnesota on that, because often when we look at outcomes, we look at, did I do a mental health screening? Well, I can tell you doing a mental health screening has very little value at the end of the day to the individual you screened. Just means you screened them. But getting a different mental health outcome for the individual is where we want to put our dollars. So I think it's marrying the dollars and the flexibility to those data, but making sure the data is really about outcomes, not about tests and procedures and process.
So this is the change in the mindset from the fee-for-service idea. Paul, you're running a physician association. You're not, big bad Blue Cross or another health plan that's got vast sums of money. It must be pretty scary to be changing how you deliver care, wondering if you're going to be able to continue to pay doctors and the other folks who work with you.
It can be. A lot of the work you're doing in change is you're balancing between career limiting, which is also being fired, or actually improving the outcome. And I think if you're in it for the right reasons, I always look at it as improving the outcome. And you talk about whether it's aligned incentives, whether it's the drivers of change. I think the biggest drivers of change is you have to believe that you cannot keep the status quo. And if you believe that, then you have to change. I mean, it's that simple. And Garrett, in his CEO of Blue Cross Blue Shield, sat through one of our medical staff meetings, and they heard firsthand the cultural pressure of providers saying, you want us to change, that's all well and good, we're ready to change, but how do we do it in an effective manner? I think one of the challenges is that when you're looking at this and you're saying doctors are burning out, they can't continue doing what they're doing and try to see more and more patients to try to keep the bills paid. You have to improve quality, there's no question about it. And to do that, you can't do that without resources. But the fee-for-service model does not provide effective means of aligning those goals and objectives. And so you have to leave the fee-for-service model. That's simply a volume-based system. If you want more volume, continue to pay fee-for-service. We'll do it. We'll just work harder and we'll generate more money. That's fine. But it won't generate better outcomes. So how do you get around, and I don't have the answer. If I did, we'd be rich. Because everyone's looking for this holy grail is how do you get to a process that pays for outcomes? Not just quality, because there are people that will argue some of the measures we measure aren't practical quality measures. They're process measures, which was mentioned earlier, one of the earlier discussions. But how do you get to the fact that, did I improve Mr. or Mrs. Jones's health? Yes or no? Are they feeling better about themselves? Is their life better? Do we somehow improve and address the social determinants that got them to where they're at, which is what Jennifer's referring to, which I think is just an amazing area we can make headway in. But it can't be done under fee-for-service. It just can't. So that's the leverage.
Yeah, thank you. Garrett, you talked about the importance of consumer-based, consumer-driven model. And there have been a series of questions all day from folks here about that idea. And here's one. Market reforms are talked about all the time, yet healthcare is not a traditional market. Consumers are limited in their ability to shop. Why do we keep talking about healthcare markets, given all the limitations to them?
Well, I agree that consumers are limited in their ability to make informed healthcare choices, but that doesn't mean that I accept that. And it doesn't mean that I think we should accept it as fait accompli, that we can't have more usable, digestible information for consumers to make healthcare decisions. You could look at your healthcare decisions, when tomorrow I may have a diagnosis, and that diagnosis may lead to I need a treatment, and then I want to go to I want to know what my best options are. What are the best destinations I need to get to? That's all possible. We measure it. We can measure outcomes. We can look at cost. All that's possible. But then I may have a diagnosis where it's a chronic condition. There's no particular place for me to go. It's about me learning how to live with a new set of realities in my life. And this is very important, I think, as Jennifer's referencing, for the people on public programs, is they may not have the social means to be able to navigate all the complexity that a major health change in their health status can bring in. And that's where it's very important to look at, their transportation, their ability to understand how providers are talking to them, how it affects their ability to be part of a different community. So I do think that consumerism in healthcare is going to come from the outside, and it's going to, if I think about banking 10 years ago, the banking industry was kind of where the healthcare industry is. Fee-for-service drives transactional, fragmented behavior. But I think the banking industry has figured out, not perfectly, but they've been able to have more personalization in terms of how they interact with individuals. And I think that same sort of kind of outside-in disruption is what the healthcare system will see. It's going to come from people that look at how do they use information to drive decision-making and change. So it's probably going to come from Silicon Valley, not from Blue Cross, or at least maybe not from the providers. In some ways, we're so close to our business model, and changing it is such a high-risk proposition that it's very hard for us to do big, bold disruption.
But I think that you put your finger on one of the tensions today, which is when you look at the transformation in other parts of our consumer world, a lot of it is driven by the consumer. Amazon or Expedia or just on down the list. The challenge that is healthcare is not the same as those other markets, and so how is it that you negotiate the creation of information that's as simple as going on Amazon and getting a score on the best toaster, to something as complicated as making decisions about a medical provider?
Yeah. Well, I agree. Not everything is shoppable in healthcare, and nor should it be, but some things are. And I go back to the data analytics discussion and kind of challenge. It seems like we're so focused on the real concerns around how do we acquire the right information and get that into the hands of the people that need it. Providers that are involved in a course of care, the individual, the health plan. I actually see the bigger challenges in application of information. We really don't have a shortage of data in healthcare. We're having a real challenge in applying it. So we've had many conversations with NCHIRA around, they come to us and say, here's the type of information we want to understand about downstream cost. related to orthopedics, cardiac care, obstetrical care, and we're evolving that information in a usable set for, the doctors to use to decide.
So that's a very important distinction, because we have been talking about data as if you were the consumer on Amazon. And what the conversation now, and actually earlier, was focused on the use of data by providers and health plans. And I think that's a more useful way to, at least at this point, focus.
Well, there are several parts of the data, though, I think that are important to note. First of all, we do collect a lot of data and report it. We have a gem in the state, Minnesota Community Measure. That measures cost for all providers, and now is adding for public reporting resource utilization, because those are the two components of the cost. Price is one, but then the amount of services they provide at those prices gives you the total cost. The other problem that we have that we're always discussing between the payers and we want to be able to use with our patients is that when we're sending a patient somewhere, we want to give them information. How do you choose wisely and where you're going to go? So an echocardiogram at one office, that's a clinic-based echocardiogram, is $280. That's the technical component, and that's the read from the cardiologist. At another place, which is facility-based, it's $1,400. Now, same echo. Why not do that? Paracentesis, this is even funnier, although it's a little more limited, is a draining of your abdomen, your peritoneum. People with ascites and who have cirrhosis of the liver or heart failure may have that. So you can get it done at the radiologist's office for $298. Or you can go over to by the way, that's the radiologist and the sonographer doing that. You can have the same radiologist, same sonographer over at the hospital doing that for you for, again, close to $1,400. Same outcomes, same people, same service, different location. Okay, huge cost differences.
But is that incumbent on the patient who's come in with an ailment and is being sent to one or the other, or is it incumbent on the integrated delivery system?
Well, I think it's a mixture, because it's incumbent on us to, when we're recommending a service, to be able to have that information to help the decision process.
Right.
It's incumbent upon the payers to provide that data as best as possible, and it's hard because a lot of our contracts that we have say, sorry, our price is proprietary.
Right.
I'm happy to open it up. I don't care. Transparent. How can you shop if you don't know the price?
Right.
And I would push us a step further, because that's a discussion about system design internal to healthcare. And what you mentioned on an earlier presentation is, how do we start thinking about if above 80% of health in Minnesota is driven by what the individual does? You give a test, you give a diagnosis in the clinical sphere, but we're not using our public health leverage to get in front of individuals to say, you just were diagnosed with diabetes or some other long-term ailment, and now we're investing in getting that health coach in front of them to say what life choices need to change, what are you interested and willing to do, what barriers are in your way. That small investment upstream is what will prevent those more expensive diagnoses and inpatient admissions and amputations and everything else downstream, if in Minnesota we can switch from that fee-for-service model to really investing in the tools individuals need.
So, Jennifer, let me follow up, because I've actually got a stack of questions here for you. One is just a descriptive question from a member of our audience saying, what is Hennepin Health? Is it a hospital? Is it a clinic? Is it a payer? Is it a social service agency? So
Yes.
It's all those things. Yeah. What's your, the one-sentence elevator speech on what is Hennepin's?
It really is taking all of those systems and trying to work together. So instead of having the one-offs where I, the consumer, have the onus to go to each of those entities and try to connect the dots, it's connecting the dots for individuals so that it is seamless for individuals using the services. It's bringing those all together.
So I think of the case of an individual, let's call an indigent male who's been to the hospital, let's say, a dozen times in a month. And Hennepin Health goes out, identifies this individual because it's showing up from the data as a frequent hospital emergency room user. Then there's a caseworker, social worker, who identifies, visits that individual, signs them up for Medicaid, and then this organization, this ACO, is given a payment, a flat payment from Minnesota Medicaid to engage, figure out whether it's social services, whether it's the kind of life, kind of health coaching that you're talking about, or if they need medical care, but outside of a hospital. Is that the basic idea?
It is. I mean, it's just like if I'm an individual and I sign up for Blue Cross Blue Shield or I choose Hennepin Health. It is an insurance product, but what we're looking to do is really bring the systems together and work differently so that we're not worried about, well, that's their problem. If they're in the jail, it's not my problem. It's not my problem if they're over in a shelter. It is really to say, how do we bring all of those funding streams together to get better outcomes for people?
And it's very proactive because the data is identifying this pretty small number of individuals who are high cost, high risk, and keep landing in emergency rooms, which is, of course, the most expensive setting.
Right, and part of that is data sharing, as Garrett mentioned earlier. The health plans have, when people are filling their prescriptions, where are they filling them, how many are they filling? If we can give those tools to providers, they can make better decisions if they see that somebody's drug seeking and maybe hopping between 11 different pharmacies or 12 different providers. All of that systems work coming together helps us all make better decisions.
We've been talking several points today about the difficulty of the Affordable Care organizations. There was a lot of hope after the Affordable Care Act was passed in 2010 that the ACOs would be a whole new model, though there were also people who wondered if it would really amount to much. And I think the latter group have the upper hand at this point. There's more skepticism, and some of the data that's come in has raised some questions. Here's a question from an audience. Can a non-public ACO achieve the same results as Hennepin Health?
Absolutely, and please do. I think one of the things we challenge with is people go, why aren't you trademarking Hennepin Health? Why aren't you selling it? Well, that would be a business model. As local government, if everybody does it differently, we win. And by the we, I mean not just government, you all as taxpayers into government. It's that if we can spend our dollars smarter, we can all do it better. It is about having those discussions. So part of what has taught us in Hennepin Health, where we have some waste in the system, an example would be chronic inebriates who are hitting emergency departments. High cost, low outcome, so let's invest differently. So in Hennepin County, we're bringing up a withdrawal management area where instead of going to the emergency department, we can provide lower cost, better outcomes, connections into the community services. Well, we walk those to other health plans and say, do you want to buy this as well? It's better for people. So it is the partnerships, and it's all of us looking for where is there waste in the system, track the dollars to where are the dollars, and that's the person you need to be talking to about spending those dollars wiser.
So
Well,
Garrett?
and just
please.
to tag on, to Jennifer's comments, from a Blue Cross standpoint, we have the 10 largest integrated care delivery systems in an ACO payment model. It works. Healthcare in those systems is still increasing, but it's increasing at a slower rate than fee-for-service. They're also getting better outcomes. The challenge is it still only represents 2% of total payments from Blue Cross to providers, so it's a scale issue. And I think, this whole business model discussion is, it's pretty risky to change 98% of your business model. It's a lot less risky to change 2%. So I think what we have to do is kind of grow kind of change the proportionality so we can, not trying to change everything at once means you're not going to change anything. And I think given the innate complexity in healthcare around the data, clinician behavior, culture, financing, all of those things are too complex to change all at once. We need to create a safe zone where we can experiment. And I really think that's been, maybe the embodiment of the spirit of Hennepin Health is they have some latitude to change, and that's what we've been trying to create with Enchira as well.
I would say the inspiration for Hennepin Health was a near-death experience from the medical assistance program being block granted. And I remember some really pretty bleak conversations about what was happening. You could see a sense of, circling in a toilet. I mean, it was the necessity that became the mother of invention. Garrett, let me pick up though, because I think you've raised just the right point, which is 98% is too much. You've got to pick where to kind of focus. So enlighten us. Where would be the point that's kind of digestible, feasible, and meaningful to really focus, significant reform, payment, and delivery?
Well, I think I think the payment system has to be at least 10% value-based, 10% of total revenue, not members. And I think ideally, we'd want it to about 30% of all revenue is value-based, because then you have critical mass and you can start to recoup your investment that you need to make in building the data, the care coordination systems. I would love nothing better than to see the 2% grow to 20%. For me, it's finding provider partners that can kind of change at that pace, and some can move faster than others, but for me, the minimum is 10, and we would need to get up to 30 ideally.
And I would add to that it's hard in a provider system to say you're in fee for service 90% of the time and 10% you're value based. Well, it's really hard to get your clinician attention to that 10% when it's not the preponderance of what they're doing. Right. What we found in Hennepin Health early on is we needed to set a floor for our clinicians and for our providers. Is we needed to say we want you more in than out. So ideally, I would say if we could get clinicians over 50% of your business is value based, you've got to get their attention. But we also have to set a risk corridor. So there's got to be a floor, and that's what we did. Is we told our partners we're all in, but we're going to set that you can't lose beyond a certain threshold, so that we knew that they could take the risk and survive it.
Yeah, that was a risk. Because you could have had a lot of the downward cost on that could have been substantial, and what you're embarking on was so new. The cost models were estimates. Let me ask you, there's a lot of attention on Hennepin Health in Minnesota around the country. And of course, there have been other county-based efforts in Minnesota, in the south and the north and elsewhere. And there's interest around the country in looking at these sort of county-based models with flat payment from Medicaid and this idea of integrated continuum of care and a total cost of care payment model. What are the lessons? What would be you must do these two things to succeed?
I would say prospective funding. So the biggest thing we hear from providers is it's really hard to change my system if I can't invest up front in a better model. So there is some investment that's needed up front to get providers to be able to safely change the system. It is using business cases and return on investment models. So how do we invest smarter and free up dollars, which is what allows us year over year to continue to innovate without constantly having to do new influx of money. And then I would say it's the data driven. So looking at those outcomes, as somebody who is knee deep right now in child protection, I see where not investing in our families early on is costing us a heck of a lot of resources in lost futures for youth later on. So how do we make sure we're using data to invest in people and getting upstream for those payments?
This is a moment when Medicaid in particular and public assistance programs, public programs in Minnesota and other states are under serious questions. And the kind of work you're doing suggests that there are different models, and it's not just kind of this kind of government control, that there's more innovation going on there than I think a lot of people appreciate. What's going on in Hennepin Health is one of those stories people are telling around the country, and I can say that from the national conferences. Garrett, I want to pick up on a point that Governor Pawlenty made when I asked him, why the 2008 task force, why this kind of push, about a decade ago, that brought so many different parties together. And his response was, we had no choice. Healthcare costs were going up. And I want to ask you, do you feel that the rise in premiums in Minnesota, obviously it's individual market, but we're seeing it in other parts of the insurance market. Do you think that's creating a pressure for the kind of transformation, delivery, and payment that you've been talking about this morning?
Yeah, I definitely do, and we have stopped talking about something in health reform that's very uncomfortable. and that is, what is an acceptable rate of growth in healthcare costs year over year? And I think we haven't been talking about that the last few years. I think you have to set the individual market aside because there was a lot of volatility in that market that was unique to Minnesota and how the ACA impacted our individual market. But if I look at healthcare costs in Minnesota are still outpacing inflation by 3x. And so it just keeps growing and growing. And while we may be happy that our rate of growth is lower than other parts of the country, it's still, I don't view it as a political issue. Whatever your set of political priorities are, if we can't come up with a year-over-year increase in healthcare costs that are near the rate of general inflation, it means that whatever social or political priorities you have, there's less money for it because healthcare keeps growing and growing and growing. So I do think, the impetus is still there, and it will continue to be there at the federal level, the state level, and from the employer level and the individual purchaser level as well.
Great. I want to thank this terrific panel Jennifer DeCabellas, Garrett, and Paul Beresford. Thank you very much. It's terrific. And then we have our last panel, our legislators. We've got Minority Leader Paul Thiessen, who's been here all morning, keeping vigorous notes. He probably has writer's cramp by now. And Nick Zerwas, who's a Republican in the House, and very thoughtful. This is, I think, our third program on health together. And really appreciate Representative Zerwas's insights and willingness to raise sometimes uncomfortable questions. So thank you very much. Both of you have been here all morning. So I've got a bunch of questions here, many from the audience. But let me just start. Representative Zerwas, what is it that you see as the agenda moving forward, and what can the legislature do to help that agenda?
Well, I think there's a broad agenda of trying to deliver health care to as many people as possible in the state of Minnesota at as affordable of a cost as possible. And I think some of the folks on the panel and Governor Pawlenty kind of keyed it off very well. And I think some folks that have identified, certainly in the last 3 years, a big challenge in St. Paul and at the legislature is anytime we talk, even in very broad strokes, about health care and providing health care to Minnesotans across a very diverse population and a diverse geography of the state, there is kind of the challenge around Minnesota's implementation of the Affordable Care Act that in some settings and in some instances sucks the air out of the room and really limits, if not inhibits, policy discussion about moving Minnesota forward and doing what's best for residents. So I think as I look at St. Paul, there are some kind of natural barriers to this broader based policy discussion, but certainly there's room to have that discussion.
That's a really excellent starting point. And Leader Thiessen, you've been part of these conversations for so long, and you've been an important and thoughtful voice about them. I want to pick up on that. Is it your sense that maybe the way in which the reform or the Affordable Care Act and MNsure has gone about has perhaps in an unanticipated way created difficulties in talking about this broader agenda that for so many decades wasn't political really at all. It was a pretty broadly shared.
Yeah, no, well, I do think that's absolutely the case. I think taking the air out of the room is exactly what has happened in some sense. And you heard it today. I mean, some of the things that even were said today about, the business community's reaction and drawing back from participation, partly because they're so focused on figuring out how to deal with the ACA, and partly because they don't, they feel like their voice has been limited. I think that's a pretty insightful comment. you know, the ACA was about insurance reform, and we've been fighting about insurance for, you know, the last 5 years, whereas a lot of the work in 2008 was really about healthcare reform. And there were bits and pieces in the ACA, as we've talked about today, that moved in that direction, but that got lost in this in what has become a very partisan political debate. And some of that is the way it was enacted, of course, on a purely partisan vote, you know, and whether you can go back and rethink that. And even in Minnesota, the implementation of it has been on pretty partisan lines, you know, the expansion of Medicaid and the implementation of the exchange, all of that, you know, has been done primarily along party lines, and I think that has had a significant impact on our ability to have these broader discussions that kind of underlie what these premium increases really are about, which is that we haven't cracked the cost of healthcare.
Do you see a path back to the kind of Palenti, Berglund, Huntley kinds of and Thiessen conversations? I mean, how do you get back to a conversation that is meaningful, constructive, and
well, I think part of it is, you know, one of the things I thought was great about, well, two things I thought was great about the 2008 effort. And the way I talked about it at the time is really what the legislature was trying to do was ride the wave that was already happening outside of the Capitol. There was lots of discussion about payment reform outside the Capitol before we ever started talking about it, you know, in the Transformation Task Force and other places. So I think trying to reorient our focus within the legislature on what's happening outside, that's why I thought the panel we just heard was so terrific, is one way we can get past that. You know, I think a willingness on the part of Democrats to be able to step back from the exchange. I don't think that we necessarily give up on the exchange because I think there's a lot of benefits that come from that, but to acknowledge more than we have that there are problems there, and for the Republicans to acknowledge that there have been some benefits that have come from that, including lower, you know, greater access, and to give a little bit more breathing space for it to evolve. I think that's a place that we could move, but more importantly, I think we should just, you know, set it aside a little bit for a while and come back to this question of how do we actually start to drive down healthcare costs and what models are working out there, and move away from insurance and back to healthcare.
Thank you. Representative Zaros, what are your reactions to that?
No, and I think Representative Thiessen is pretty accurate in his to the extent that for the broader based reforms, for that discussion to happen, it's probably going to have to happen to some extent, you know, around the edges of the exchange that we have in place. I don't see in the next few years, I don't see any move that we would get rid of the exchange. I think the governor's been pretty sad that that's something he's not willing to do at this point. And so when we look at what are other things that we can do to talk about, I think Garrett's point earlier about the scope of just 2% for that ACO model, I think that's pretty striking in that it's one of the innovation things that we end up talking about quite a bit at the Capitol, and it's one of the few areas that we do hear kind of hopeful news from. It's interesting within the Hennepin Health model, Minnesota has one of the challenges, we've spent a lot of time talking about data. The Minnesota Data Practices Act, which is stricter than HIPAA, the federal guidelines, really in many ways impacts how providers can most effectively share data and information to drive some of those healthcare decisions. And so that even in Hennepin Health's model, we had to pass some language at the legislature to allow more of that data sharing to be allowed between the social service aspect and the healthcare aspect to really capitalize on those relationships. And so I think there's a lot of discussion that can be had in St. Paul that deals with how can we most effectively make Minnesota an appropriate and collaborative environment for those types of cooperations.
Let me just follow up on Leader Thiessen's I thought, really quite eloquent statement about kind of moving back a little bit from the insurance debate and the political partisan toxicity of that. Do you think that's possible from the Republican side? To me, sometimes I talk to people, even privately, and it looks like they got a bone in their mouth, and it's kind of like, okay, let's talk about something else. And I'm not really seeing signs, and I don't mean to overgeneralize, but a few people seem to be so stuck on that you can't really talk about anything else.
Well, certainly, I think you have a group of Republicans, certainly in St. Paul, that try to identify potential pitfalls, try to identify issues that they had grave concerns about, and then as the system has rolled out and as those fears have been realized, you have a pretty broad base of Republicans that really are at the point of saying, "I told you so." And I think kind of okay, now what? And I think that's the step that we're entering now is if you were right, and if you're convinced you were right because these things that you said might happen are in fact happening, what is the next stage of that rather than pointing out the problems? And so I know at the MNsure Executive Board meeting just last week or maybe 2 weeks ago, they brought in some potential outside vendor presentations about taking some of that outside of state government and trying to run the back end of stuff that patients don't interact with, but severely hinder the operation and the county's interaction with MNsure, trying to take that over and shift that to the private market, well, to a company that the presenter showed that in 12 other states they've done that transition. They've done it very smoothly. So I think there are discussions about the very technical end of what to do with a very struggling infrastructure, but broadly based, I think now is the time to talk about, besides that struggling component, what are the other healthcare interactions that we can more directly attack.
And Leader Thiessen, you've been, I think, quite vocal in talking about some reforms already. I think the bill you dropped on reforming the Department of Human Services. It's not usually the kind of bill I think of, a DFLer talking about maybe breaking up a large government department because of lack of responsiveness and accountability. And do you think there is this kind of possibility of kind of moving past the MNsure debate, the Medicaid expansion debate, taking a kind of hard look about government performance? And
Well, right, and I do think that's the part where the Democrats do need to step up and where we can engage around this issue. I think the other crisis that's coming that's going to prompt reform, kind of like the GAMC situation that we faced back, in the mid 2000s, is going to be what we do when the provider tax goes away, if it goes away. I mean, that's going to cause huge changes in what hospitals are going to be able to be reimbursed, and I think how we resolve that, which is going to be coming up here, in the next biennium, is going to drive, I think, could drive some of this reform discussion again. I mean, to hear the folks from Hennepin Health say that we don't need any more money in the system, which I think there probably is some truth to that, but then how do we get there in a way? And, I come back to the GAMC experience. I mean, that's really what drove Hennepin County ultimately to get there, right? And the experience, we just didn't, I hated it at the time because we didn't fund it. But if we fund a model like that, I think it could go a long way. So I didn't really answer your question. I don't even remember what it was. But
No, you did.
Okay.
What would be some concrete reforms that would be in the spirit of let's call it the 2008 Transformation Task Force spirit? How do you get back to that? What would be? Is it a task force? Is it how would you define it?
Well, maybe it's a task force. Maureen Reed made an interesting point in the break, saying one of the unique things about how the task force was set up was it's set up with very specific outcome goals, like you need to figure out a way to cut costs by 20%. And we don't often do that. So maybe there is coming back to a much more specific legislative directive of figure out how you get there and come up with some provisions. But I think some of the things coming out of the most recent task force, when people are talking about direct contracting, is something that that the state could start to drive some of that change. I think the public health work that we did was one of the great success. I mean, the SHIP program and healthcare homes to an extent did have the impact of bringing down costs and some of the things and learnings that flowed from that. One of the things with the breakup of the, I don't know, the breakup of driving the DHS breakup bill was conversations I've had, where the federal money runs to DHS. And then they dole it out, mental health being an example. They dole it out, and health has kind of the upstream stuff, the Department of Health. But because the money starts in DHS, that money, doesn't get up there. So there's some bureaucratic things I think we can change to actually reallocate money within our state system, which are more structural driven than kind of thoughtful. So I think that there are some significant changes we can make. I also think that the emphasis that we're starting to put on mental health in the state is something that could actually have a very significant impact on our ultimate outcomes in some of these healthcare costs as well. The thing I most like, though, about the discussion today, because all this seems so overwhelming, is that we don't have to attack the whole system. I mean, the Governor Plenty said, he pointed out, if we can deal with diabetes and, heart stuff, and I think mental health, we can take care of some of those small things, it actually is going to solve most of the problem. And I think that's another way we need to start thinking about this.
Representative Zaros?
Well, and I think in Representative Thiessen's proposal, looking at DHS as kind of this broad, kind of unwieldy beast of an organization, I think there's a lot of that has a lot of truth, and one of the things that I wish we could have done is dug into that this session. I was advocating for your ability to hearing, just so you know, because I think that's very much worth the discussion. Because I think you do have issues and concerns with direct lines of accountability and really chains of command, and you deal with whether you're talking in one hand about the St. Peter facility, or the next hand about the Anoka Metro Regional Treatment Center, and then in the next breath, now we're talking about the sex offender program, the Minnesota Sex Offender Program, and it's kind of taken everything out of you, and you haven't done anything about the broader based public programs, child protection, and some of the other broad issues that are under there. So I think it certainly deserves a look at. We talk a lot about, everyone always talks about silos and the silos in DHS, and we were at another presentation, and I mentioned this before, but I was talking to someone and they said, well, we don't really operate in silos. We operate in cylinders of excellence. So, which I think is just a great, you couldn't get any more government than that. And I think that's just, it's so quintessential of some of the challenges facing an organization like DHS. And I think looking at a reorg is certainly worth the time and effort.
Thank you. Leader Thiessen, one of the themes over the last couple of decades or more has been Minnesota's commitment to collecting data and sharing that data across providers and trying to create data that's usable. Minnesota Community Measurement is a national leader and a model for that, but there have been other efforts. When you think back over that discussion about data collection and its use, what's the right way to think about it? What is the kind of proper responsibility and emphasis and use of payment data, of quality data in terms of providers?
Right. Well, I mean, from my perspective, it's data is only as good as the people interpreting it and having the information to interpret it. And in healthcare, that can get very complicated very quickly. And so, getting some information in the hands of consumers, in an easy way, I think makes some sense so they can make some decisions. I thought one of the most interesting pieces today was the idea that I think Noam Levy's, made the point. There's only a small percentage that's even shoppable. So to me, it's more getting the data in the hands of first the providers, so that they can use that kind of human competitiveness to change their behavior, and then secondly, to use it to structure insurance models. And we can use the exchange to do some of this, I think. Insurance models, so that for procedures we know work, we should just let people get them with no copay. And if they want something that has, is much more expensive but minimal, incremental value, they're going to have to pay a lot more for it. And that was one of the things we actually talked about at the time of the 2008 with the Transformation Task Force report, is how can we build an evidence-based insurance model. I think that it's happening a little bit in the private sector, but not nearly as much as it could based on all of the data we have right now. So I think it's more getting in the hands of people who actually know how to use the data, and then letting them create systems that nudge people in the right direction who don't have the time to really immerse themselves in it.
So that's a shift away from the kind of
Consumer.
The kind of market model idea with consumers as discerning shoppers and so forth. There is, as you know, a component of the Affordable Care Act that allows starting next year for waivers.
Yeah.
And there's been a lot of conversations and the waivers are extraordinarily broad. I mean, you can do a lot of different things. Utah looks like it's talking about a much more of a market-oriented approach. Vermont had talked for a while, no longer about a single-payer approach. So the door swings open here. Do you think the waiver could be used in Minnesota to focus on delivery and payment reform?
Sure. Yes. I don't know if I have more to say than that. No, I mean, absolutely. I think the waiver brings a lot of opportunity to do that and kind of give more flexibility, like Hennepin Health was just talking about, in terms of how you use Medicaid dollars and fit all those dollars together. That kind of flexibility, it's not a very democratic thing to say, but when people in Washington start talking about block grants, they don't like the block grants from the perspective of they limit the amount of money. But I love the idea of block grants, that the federal government is not going to be telling us at the state what to do. So if we could get more flexibility that way, would be great. The risk, though, and we saw this in the 2008 task force too, is that kind of the ideas that were brought forward, including mandatory, basically what became the ACA, that you have to have insurance, and that we're going to get rid of pre-existing conditions and all those things. That was in the report. In our caucus, we ran into a big push from the single payer folks that said we don't want to go there because we want to get to single payer. And I think in the other caucus, it probably was just the opposite. So this ability to get flexibility also creates political challenges too about, what people really believe that they can deliver versus what's ultimately able to pass the legislature. And so we got to, navigate that road carefully.
Representative Zerwas, I'm going to pick up on an issue where you've been one of the leaders in the state, which is thinking about the use of non-physician providers. Could you talk a little bit about that, particularly in the context of a system that is now expanding access to healthcare and the challenge in Minnesota, which is, it's a big state. Geographically, we've got 87 counties, and a lot of those counties don't have, kind of a metro-style set of providers.
And I think we see that really all across the state, the challenge of getting providers and to get enough providers to the patient, and kind of the old model of you have a physician and they might have a PA, and then you have a nurse, and kind of what can be done kind of beyond that. And so we look at now in care systems that have everything from, a physician to a physician assistant, but a myriad of advanced practice nurses that have subspecialties going from mental health, advanced practice nurse practitioners, physician assistant, mental health practitioners, which could be huge stopgaps in greater Minnesota in generally underserved population. It's interesting, we've kind of had a perennial debate around Medicaid reimbursement, MA reimbursement for a non-physician mental health provider. And we've had advocacy groups say, well, if our folks need to see someone for mental health services, they deserve to see a doctor. And our argument has always been, well, to see a psychiatrist might be a 6 or 8 week wait. But we can get you in to see a very qualified, very ready to treat advanced practice nurse, mental health specialist in 2 days. So is it better for your person to wait 2 months to see a doctor when clinically in what will be prescribed and what will be done, there is negligible difference, and private insurance already reimburses that nurse practitioner already. It's just this public program debate that we're talking about. So that's one of the issues that we addressed last year. It's all about access. We see the same thing in dental care. We have about a dozen and a half counties in Minnesota that don't have dentists, don't have dental providers. And so we have dental therapists that can get in and work in conjunction under the umbrella of a dentist and do huge components of what general dentistry involves, including filling cavities and doing some other dental work. So those are all keys, especially on the dental end of things, when in Minnesota, as we like to talk about us being leaders in healthcare and kind of wear our rotator cuff out, patting ourselves on the back. Minnesota rates 48th out of 50 for our MA dental reimbursement rate for adults, and we are 50th out of 50 for pediatric dental reimbursement rates for our public program children on Medicaid. And so it's a pretty sad state of affairs when Arkansas and Louisiana have better dental care programs for public programs than our state. And so we need to realize that a huge component of that and where we're at because of our reimbursement rates is utilizing providers at all levels of practice. And in the last session, we built on, and in this session there's another bill that looks at, again, using that whole scope for providers and who can fill the niche to serve the right people in the right locations. And we've identified community EMTs and community paramedics to put really high-risk patients that are going out, being discharged from the hospital, that have a higher rate of readmittance, and having community providers go in the day after or 2 days after discharge to check in on those patients, to make sure they're taking their medications. If you've been discharged from after being treated for congestive heart failure, have you taken your digoxin? Have you taken your Lasix? Do you know where to go for your cardiac rehab next week? That type of follow-up work we can do at a fraction of the cost of paying for one of those patients to be readmitted back into the hospital.
As you can see, Representative Zerwas is one of the state experts on this. And it's interesting that Hennepin Health has been, really relied on the use of non-physician providers, and then, frankly, community health workers, which is a whole new class or growing class of folks, both in the Medicaid population, but the community health clinics and other settings. Representative Thissen, we're almost out of time. I want to ask you about one of the important debates going on in the state, which is about racial disparities. Do you see a way in which our conversation today about healthcare delivery can address the disparities across racial groups in health?
Well, it certainly should, and I think some of the challenges, there's two things or three things I guess I would say. One is, I think one of the places that we really can change the disparities thing is looking at it on the public health side as opposed to the delivery system side. That's where I think a lot of the gaps come from. And so to the extent that we can start shifting resources out of kind of the hospital delivery model and move it more toward public health work as we move forward, I think that, and so changing the delivery model to the extent it can save up money will free up money to do that.
Could you give an example of kind of where you put resources into public health that might directly affect racial disparities?
Well, I think if you look at public health kind of broadly seen from the perspective, one example, would be lead, right? Poisoning, which affects communities of color much more significantly. And so doing more work from a public health or the health department perspective on rental properties as opposed to homes could make a huge difference. But that would take some resources to get out there, but it's more of a public health initiative. So that would be one, diabetes would probably be another example, how, so those are some, on Native American reservations, dealing with some of the opioid addiction stuff, right, which is a public health effort as opposed to a kind of medical delivery method. I think readjusting some of our resources to do that. So that's one thing. A second thing is, providing more flexibility. This total cost of care model would allow for people to do the kind of outreach that would help poor people, which does correlate, kind of with these racial disparities in a way, what Hennepin Health, what Senator Berglund was talking about. But I also want to say that there are, institutional racism problems endemic in all of our systems. And I don't know if delivery reform is going to get at some of those issues. It's resource allocation into certain communities and not others. I think you have to be just much more intentional in other ways as opposed to just kind of hoping that the payment reform system solves it. So I think it can go part of the way, but certainly wouldn't solve the problem.
Do community health clinics have a role here?
Oh, certainly, yes. And getting them in the right place.
Because that would seem like an area where, in terms of resource allocation, they've grown enormously, of course, since the Affordable Care Act, and even just before the Affordable Care Act through the stimulus bill. But that would be, and Minnesota, of course, throughout Hennepin County and other parts of the state, rural parts of the state, these clinics have become a larger, more important part. It's not focused on insurance, it's focused on delivery.
Yeah. No, that's a very good, yeah, absolutely.
I think,
Representative Zeros.
just briefly, I think the federally qualified health centers, freeing up and looking at scopes of practice for all providers so that in these traditionally very underserved populations within the urban core can be addressed with a myriad of providers. There are many examples of community dental clinics that are staffed almost entirely by dental therapists that are doing community outreach on a daily basis and seeing just volumes and volumes of patients based off a reimbursement rate that with a traditional dentist model wouldn't be done. And then I think there's the other part. I know kind of data is getting a little bit of a bum rap in that it's not on the consumer end of it, but I think there's a lot of data in Minnesota Community Measurements and others have been a part of it, is really drilling down into what racial disparities in healthcare looks like for public programs and managed care programs to implement programs that are really specified. It's one thing to say African American men have a really troubled time managing diabetes and have a huge cost driver for diabetes. It's another thing to drive further into that data and realize that when you really drive into it, you're looking at 18 or 34 to 58-year-old Somali-aged males that significantly underperform compared to African-American peer groups in how they manage their sugar levels and how they manage their chronic diabetes condition. And so providing that data and that information back to those managed care organizations with those populations to further focus resources into very specific points in neighborhoods. And with some of that data out of Minnesota Community Measurements, we can literally drill down to a zip code and identify areas and try to identify neighborhoods that need that extra assistance.
Yeah, this partly what Hennepin Health was doing in identifying those high-risk groups. Did you want to close?
The only thing I would, yeah, and I think that there's a lot of that is exactly right. The only thing I was thinking, we want to warn ourselves against is creating a two-tiered system too, right? So we set up certain types of clinics in certain neighborhoods with certain set of providers and different types of clinics with a different set of providers in different neighborhoods. We have to be careful about going too far down that path as well and kind of further dividing things if that makes sense. So
I want to thank Representative Nick Zerwas and Minority Leader Paul Thiessen, and thank all of you for being here today. That's great. Paul, is that what you were looking for? Yeah. Okay, good.